print copies of the compilation of laws and rules relating to the congressional budget process. Without objection, so ordered. I recognize the gentleman from Indiana.
I ask unanimous consent that the staff be authorized to make technical, conforming, or stylistic changes to the committee rules and oversight plan, that the rules of the committee on the budget be issued as a committee print, that the chairman be authorized to submit the rules for printing in the congressional record within 30 days, and that the chairman be authorized to submit the oversight plan to the Committee on House Administration, Oversight and Government Reform, and Appropriations.
Without objection, so ordered. That concludes the items of business on the agenda for the House Budget Committee's organizational meeting, and we will now begin today's scheduled hearing. So if we could ask our panelists to take their seats. Welcome, panelists. This hearing will focus on the failures of Obamacare, its harmful effects, and broken promises. We're having this hearing today to discuss the damage that Obamacare has done to patients, medicine, workers, and our economy. And after 6 years, no one can dispute that this law has been nothing but a series of broken promises. Patients have lost their doctors and their insurance plans. Premiums and deductibles have skyrocketed, and small businesses have been forced to reduce their benefits and wages or put off hiring of new workers altogether. Obamacare was sold as a solution that would tackle one of the biggest problems in our healthcare system, the rising cost of insurance. In fact, President Obama promised this law would lower premiums by $2,500 a year for an average family. In reality, the complete opposite has been true. Average family premiums have risen by $4,300, and deductibles have risen by 60% in the employer-sponsored market. For working folks across the country, more money out of their paychecks just to pay for health care makes life much harder. And what are Americans getting in exchange for these higher costs? Well, not much. 20 million Americans have said that Obamacare just isn't worth the cost or the trouble, choosing to pay a fine or to file an exemption instead. And for those who do have insurance, access to care hasn't improved. So while our friends on the other side of the aisle may claim that Obamacare is increasing the number of people covered, the question we would ask is, what kind of care are they receiving? For those pushed into a broken Medicaid system or having to navigate the complicated Obamacare bureaucracy, excuse me, they're not receiving the very best health care our nation has to offer. And as a nurse for over 40 years, I know that we can do better. Now, I'm sure the Democrats will cite the CBO study from last week that discusses what happens to coverage numbers if we repeal Obamacare. But what the CBO study ignores is any potential Republican ideas to reform the health care and expand access. And access to quality care is what so many people in my home state of Tennessee are lacking under this law. Let me give you an example. In our state, 28,000 people lost their coverage on a single day when Access Tennessee, which is a program that helps those that are in the risk pool, lapsed after the Obama administration decreed that it ran afoul of the federal government's top-down requirements. Yes, in one day, 28,000 people lost their insurance. This happened despite President Obama's claim that if you like your plan, you can keep it. Now, premiums in our state are rising by an average of 63%, and 3/4 of our counties only have one coverage option to choose from on the Obamacare exchange. In 5 other states around the country, Alabama, Alaska, Oklahoma, South Carolina, and Wyoming, patients only have one insurer in the marketplace to choose from. And if you only have one choice, then you're probably not going to find a plan that best fits the unique needs of you and your family. And for folks not living in the city or suburbs, Obamacare has been especially harmful. Since 2010, 80 rural hospitals have been forced to close, further restricting choice and access. But the good news is that it doesn't have to be this way. We don't have to accept Obamacare failures and broken promises. And that's why our House and Senate have worked together in this new Congress to pass a budget that begins the process to repeal Obamacare and stop the damage that it's causing. And in the coming weeks, we'll consider legislation that will roll back some of the worst aspects of this law and begin laying a foundation for a patient-centered health care system. And we already have great ideas to build on. My Tennessee colleague, who I'm very proud of, Congressman Phil Rowe, a physician, has introduced the American Health Care Reform Act, and Congressman Tom Price has offered the Empowering Patients First Act. And last year, our House Republicans put forward a better way, 37 pages of reform proposals that we will act on this year. So we've got a lot of hard work ahead of us, and today's hearing will be another critical step forward. And that's why I'm glad that today we will welcome some witnesses and get their ideas for improving health care for the American people. First, we have Grace Marie Turner, who is the president of the Galen Institute. Next, we have Dr. Robert Book, a senior director of the Healthcare System Innovation Network. We also have Edmund Haislmaier, a senior research fellow in health policy studies at the Heritage Foundation. And finally, we have Dr. Linda Blumberg, a senior fellow at Urban Institute's Health Policy Center. Thank you all for making time out of your busy schedules today to join us for discussion. Everyone on this committee looks forward to your knowledge and insight on what we can do to improve America's healthcare system. We're committed to rolling back the damage caused by Obamacare, to achieving true healthcare reform by bringing the best minds together, which we believe we have done today, and always remembering to put patients ahead of Washington's bureaucracy. We will succeed. Thank you. And with that, I yield to the ranking member, Mr. Yarmuth.
Thank you, Chairman Black. I want to join the chairman in welcoming our witnesses this morning. My Democratic colleagues and I are confused why the majority did not hold this hearing before rushing through a budget to repeal the Affordable Care Act and defund Planned Parenthood. However, we will use it as an opportunity to set the record straight about a number of things. The American people have made it clear they do not support repealing the Affordable Care Act. They rightly fear losing access to quality and affordable care and know the consequences would be disastrous. Over the weekend, millions of people across the nation rallied against the dangerous policies of the new administration, including threats to our health care. I know every one of my Democratic colleagues has heard from people whose lives have been transformed or saved because of the ACA, and there are hundreds of thousands of constituents in every congressional district across the country who have benefited from the law. Let me tell you about one of them, Steve Riggert, a constituent who recently wrote to me. Steve's daughter, Anna, was diagnosed with chronic pancreatitis at the age of 12 and has been hospitalized more than 24 times over the past 10 years for a variety of reasons. From the beginning, Steve knew that Anna's serious medical problems would make getting health insurance difficult once she transitioned out of her parents' policy. When the ACA was enacted, he was immensely relieved that she could always get coverage even though she had a pre-existing condition. But the Republican plan to repeal the ACA has now left Steve feeling, and these are his words, helpless, petrified, and literally losing sleep. At age 64, and recently diagnosed with pancreatic cancer himself, he fears that he won't be able to help his daughter. To quote his letter, repeal of all aspects of the Affordable Care Act would place everything I have worked for and those I care about in jeopardy. Steve is one of many. There are a lot more. In fact, the Congressional Budget Office, as Chairman Black mentioned, estimates repealing the major coverage provisions will cause 32 million people to lose health insurance. In the individual market, eventually 3/4 of the U.S. population will have no access to an insurer and premiums will double. But that is just the beginning. Under a full repeal of the law, insurance companies will once again be able to deny coverage based on pre-existing medical conditions. People with job-based insurance will face annual and lifetime limits on coverage and co-pays for preventive services, and seniors in Medicare will pay more for prescription drugs. Hospitals caution that repeal will increase uncompensated care costs, likely leading to service cuts, layoffs, or higher prices for everyone. Outside experts say repeal will result in 3 million lost jobs in 2019 alone. Republican governors are pleading with the Republican congressional leadership not to go through with this repeal. Despite these warnings and despite the grave consequences, here we are. I expect my Republican colleagues today, as Chairman Black's already done, will wave around bills and claim they have a plan to replace the ACA. They do not. The reality is that in nearly 7 years, Republicans have yet to introduce a single bill that has the support of the majority of their conference or comes close to matching the ACA's record of success. We will hear a lot of ideas today from my colleagues on the other side of the aisle, and I would wager that at the end of the day, these ideas will also fail to garner the majority of their conference or come close to a plan that matches the ACA's record of success. They will also not comprise a plan that any American citizen from which they could infer how it will change their lives or affect their lives. I will keep an open mind. I will ask questions, and I look forward to hearing more from our witnesses, and I yield back the balance of my time.
Thank you, Mr. Yarmouth. Panelists, the committee has received your written statements, and they will be made part of the formal record hearing. You will each have 5 minutes to deliver your oral remarks, and Ms. Turner, you may begin when you're ready.
Thank you, Chairman Black, Ranking Member Yarmouth, and members of the committee for the opportunity to testify today on the impact of the Affordable Care Act. I plan to focus primarily on families, small businesses, and young people. While members of people have received health coverage through the Affordable Care Act, many more have felt personal harm. I know that you and many members of Congress, including the leadership, have provided assurances that those currently receiving coverage through the Affordable Care Act now will have that coverage maintained as a safety net, lifeboat, while you build a bridge to new coverage that will protect people that are currently being harmed by the law, but also provide new patient-centered options for care and coverage. The costs of health care continue to be a primary concern. I rode with an Uber driver last week who said that he lives in Maryland and he has to work this second job to pay his $1,200 a month premium for himself, his wife, and his child. So he says, this is taking time away from my family, but I have to do it in order to provide them coverage. Many millions more are facing a similar fate and really are pleading for help. Young people have been particularly disadvantaged. The law requires that insurance companies charge them only 3 times less than older people, and this 3-to-1 age rating has meant that young people are required to pay 75% more for their coverage than someone just pre-Medicare age. The savings for somebody on Medicare, or 64-year-old, so just before Medicare, are only 13%. So what's happening is young people are saying this just is not a good value. They're not purchasing the coverage, and they're not entering the pools that we need them in so that they can help balance out the risks. The ACA's employer mandate also is disadvantaging them in making it much harder to get that first real job because it makes hiring them so much more costly. On families, NPR's Morning Edition had a self-employed consultant from Portland, Oregon, saying he's just not going to buy health insurance in 2017 because his premium had shot up to $930 a month. A broker said, I've got clients saying the prices are nuts and I won't pay it, I will pay the penalty instead. The Congressional Budget Office had said, as you said, Madam Chairman, 21 million people would be enrolled in the exchanges as of this time, and as of June 2016, but only about 10.5 million were. Many millions of people just don't see the value in this expensive coverage, particularly in the exchanges where premiums increased an average of 25% last year. In Kansas City, Warren Jones said that his coverage was $318 a month when he started under Obamacare in 2014. In 2017, his premium was going to be $716, so it went up 46%. He said, my wages haven't gone up close to that. In addition, many hundreds of thousands and millions of people lost the coverage they had now, but particularly, I think, egregious is those who were on the co-ops. The Congress provided $2.4 billion to provide the startup funds for these cooperative health insurance plans, and all but 5 of them have failed, causing 800,000 people to suddenly lose their coverage because the plans were not able to, for a number of reasons, but pricing their premiums properly. And then many millions of Americans have been impacted by the taxes, nearly 24 taxes, many of which go directly to the bottom line in increasing health insurance costs. Small businesses thought that they would be able to get relief, but the shop exchanges and small business tax credits that were supposed to help them were so complicated that they drew very little interest. And then finally, on Medicaid. Brian Blaze at the Mercatus Center said that in his research, 70% of Medicaid enrollees in the expansion were eligible for the program in pre-ACA rules. While many unintended consequences have resulted from the law, I think one of the saddest is how it has impacted vulnerable populations. Charles Blayhouse of Mercatus said that one of the results was to require the most sympathetic and vulnerable Medicaid populations, low-income enrollees, pregnant women, children, etc., to face more competition for health services from a marginally less vulnerable population, childless adults of somewhat higher income. A Louisiana Medicaid recipient told the New York Times, my Medicaid card is useless for me right now. It's a useless piece of plastic. I can't find an orthopedic surgeon or a pain management doctor who will take Medicaid. President Trump's executive order ordered the bureaucracy to try to provide people some initial relief, but of course only Congress can really act to change the underlying law. Thank you, Madam Chairman. I look forward to working with you, members of your committee, and hopefully both sides of the aisle in coming up with options to solve these problems.
Thank you, Ms. Turner. Dr. Book, you are recognized for 5 minutes.
Thank you, Chairman Black, Ranking Member Yarmouth, members of the committee. Thank you for the opportunity to share my research on the failures of the Affordable Care Act to achieve its goals, as well as the harmful and presumably unintended effects it has caused. Some reforms that can be enacted to make health care truly affordable for all Americans who seek it. Proponents of the ACA, both inside Congress and outside, promised that it would bring about lower health insurance premiums, better access to health care, lower health care costs for patients, lower total national health expenditures, in part due to savings on administrative costs and nonprofit co-ops, and most of all, fewer Americans foregoing health care because they can't afford to pay for it. In fact, the opposite has happened. Health insurance premiums have increased at record rates, especially, but not only, for those who have to pay for their own coverage instead of getting it at work. More health plans than ever have narrow networks of providers, limiting access to care in the name of saving money. Co-payments and deductibles are at all-time highs, and according to Gallup, more Americans than ever say they have avoided or delayed obtaining health care because they cannot afford the cost. Clearly, having health coverage does not mean that one can actually obtain health care. In addition to paying record-high premiums, families earning as little as $41,000 per year may have to spend as much as $14,300 out of pocket before obtaining any coverage for treatment of diseases or injuries, and even that coverage may be restricted to a very small network of providers. Despite all these factors making it more difficult for patients to access health care, total national spending on health care has continued to increase every year, both in dollars and as a percent of GDP. Administrative costs of insurance have increased as well, as the cost of establishing and operating the government-run exchanges vastly exceeded the savings to insurers by marketing through those exchanges. Most of the co-ops have shut down, taking their taxpayer-financed startup loans with them. One reason the ACA was passed was that we were paying too much for health care and not getting enough in return. Clearly, we are paying even more and getting even less than ever before. The problems that plagued the healthcare system before the ACA are still with us, and a new layer of problems has been added. Another reason the ACA was passed was to save lives. Proponents said that thousands of people were dying due to a lack of health coverage. If that were true, mortality rates should have decreased when the full provisions of the ACA came into effect. However, this has not happened. The Centers for Disease Control and Prevention recently reported that U.S. life expectancy dropped in 2015 for the first time since 1993. While this decrease might not be the fault of the ACA, there is certainly no increase in life expectancy or decrease of mortality for which the ACA might take credit. Medicare beneficiaries face a separate set of new obstacles. For example, the ACA mandated a federal program whose express purpose is to pay doctors and hospitals bonuses for providing less health care to seniors and the disabled. The canard hurled at health insurance companies for decades that they are denying care to patients just to save money has now become the official policy of the federal government towards its own beneficiaries. And worse, they are co-opting providers of cures by paying them bonuses to deny care and say no. In addition, the promise of health coverage for all, even just coverage, not care, has still not been achieved. On September 9, 2009, then-President Obama told a joint session of Congress that, quote, there are now more than 30 million American citizens who cannot get coverage. The latest figures from the Census Bureau indicate that as of 2015, there were still 29 million uninsured. Due to a change in definitions, these numbers might not be directly comparable, but it is quite clear that the ACA's goal of achieving coverage for everyone is far from being achieved. Last week, CBO issued an alarmist report on a possible ACA repeal, predicting based on March 2016 data that many people would lose coverage and premiums would increase if, as the report put it, portions of the ACA would be repealed. To get this result, the CBA assumed that all the ACA provisions that make coverage expensive and difficult to obtain would remain in place, but that subsidies to pay for insurance in the individual mandate would be repealed. This is a straw person argument because it is not anyone's idea of how to reform health care. Furthermore, this report was based on data obtained before 2017 premiums and enrollment data were available, and in fact, most of those premium increases they predicted have already occurred even under the ACA. In order to make health care accessible and coverage affordable, it is necessary to eliminate those factors that artificially increase prices without improving care or benefiting patients. It is imperative to repeal provisions requiring people to purchase health plans that include costly coverage for services they do not want, will not need, or will not use. People should be permitted to purchase comprehensive coverage if they so choose, or basic coverage if they so choose. Furthermore, if subsidies are to be given, they should be structured in such a way to encourage health insurers to provide coverage for individuals with pre-existing conditions by basing subsidies on health status rather than merely on income. Thank you very much, and I look forward to your questions.
Thank you, Dr. Book. Dr. Blumberg, you're recognized for 5 minutes.
Chairman Black, Ranking Member Yarmouth, and members of the committee, thank you for inviting me to testify today. The views that I express are mine alone and do not represent the views of the Urban Institute, its funders, or its sponsors. The ACA is an imperfect law, but it has generated substantial benefits since its full implementation in 2014, including increasing insurance coverage by over 20 million people, improving access to care and affordability, prohibiting insurer discrimination against the sick, catalyzing insurance market price competition in many areas for the first time, lowering the growth in per capita health care spending, and doing all this with virtually no evidence of negative effects on employment. Our analysis and that of the CBO indicates that repeal of the ACA through the reconciliation process without a replacement plan would leave the U.S. healthcare system worse off than would have been the case if the ACA was never passed. It would lead to an increase of 29.8 million uninsured in 2019, nearly doubling the uninsurance rate from 11% under the ACA to 21%. The non-group market would virtually collapse due to the loss of predominantly healthy enrollees when the individual mandate and financial assistance were eliminated, while the rules that prohibit insurer discrimination against those with health problems remained in place. Unsubsidized premiums would increase dramatically, and 3/4 of the population would not have any insurer selling non-group coverage in their area. Over 10 years, there would be an increase of $1.1 trillion in uncompensated care that would be sought from healthcare providers due to the large increase in the uninsured, but there would be no obvious source to finance this additional care. Likely, it would result in much greater financial pressures on hospitals and other healthcare providers and much more unmet medical need for households. This scenario is realistic since opponents of the ACA have not coalesced around a replacement policy, and doing so would require raising significant new revenues, making dramatic cuts in existing programs, or increasing the deficit while earning some Democratic votes, all of which are very politically challenging. Contrary to some public statements, non-group insurance markets under the ACA are not in a death spiral. Market experiences vary a lot across the country. About 40% of the population lives in areas where low-cost silver premiums decreased or increased only modestly in 2017. But about 40% of the population does live in areas with 2017 premium increases of 20% or more. In most cases, though, these increases represent adjustments to underpricing by insurers in the early years of reform. In these cases, high growth rates don't mean high premiums. In other cases, though, premiums are high because of the market power of providers and/or insurers or adverse selection into the non-group market. However, policy strategies, many of which have had bipartisan support in other contexts, could be used to address these situations, and I'll come back to that shortly. This evidence and still increasing enrollment show that it is simply not true the marketplaces are in a death spiral. However, a death spiral would occur under a repeal via reconciliation or by maintaining the ACA but neglecting the important administrative tasks that are required for the system to continue to operate effectively. The replacement proposals delineated by members of Congress thus far fall firmly in the philosophical camp of reducing the sharing of healthcare risk, separating expenses of people with significant healthcare needs from those who are healthy. These approaches may well reduce premiums for those who are currently very healthy, but they all would reduce access to adequate and affordable medical care for people with greater needs. The proposals would also do much less for those with lower incomes. These strategies include such policies as expansion of health savings accounts, replacement of income-related tax credits and expanded Medicaid eligibility with age-related tax credits, sales of insurance across state lines, continuous coverage requirements, and traditional high-risk pools. Faced with a very challenging political reality, policymakers should consider fixing the major problems they have with the ACA rather than repealing it. The following policies would address critics' concerns and also strengthen the law. Replace the individual mandate with a modified version of the late enrollment penalties currently used in Medicare Parts B and D. Eliminate the employer mandate. Replace the Cadillac tax with a cap on the tax exclusion for employer insurance with some adjustments. Improve affordability by increasing premiums and cost-sharing assistance, and extend an 8.5% of income premium cap to those with incomes above 400% of the poverty level. Doing this would allow you to loosen the 3-to-1 age rating bands. Stabilize the marketplaces by taking steps to increase enrollment, including more outreach and enrollment assistance, and allowing states to expand Medicaid up to 100% of poverty instead of 138%. Address the effects of insurer and provider market power on non-group premiums by capping provider payment rates for non-group insurers, just like the Medicare Advantage program does, and create a permanent reinsurance program to protect non-group insurers from very high-cost cases, just as Medicare Part D and Medicare Advantage have. This approach would avoid the turmoil of repeal and replace for households, healthcare providers, insurers, and state governments, and would protect access to affordable, adequate care for all individuals, regardless of health status or income. Thank you very much, and I look forward to your questions.
Thank you, Dr. Blumberg. Mr. Haislmaier, you're recognized for 5 minutes.
Thank you, Madam Chairman, and Mr. Yarmouth, Ranking Member. I have submitted, of course, testimony which I will briefly summarize. I am a senior research fellow in health policy at the Heritage Foundation, and the testimony is my own and is not and should not be construed as an official position of the Heritage Foundation or anyone else. I'm testifying in response to the committee's request to present the analysis of health insurance enrollment data that I've been conducting, basically looking at the areas that have been most affected by the key provisions of the Affordable Care Act. That would be the expansion of Medicaid and the introduction of subsidized coverage through the exchanges for the individual market and the related rules governing the individual and employer market, particularly the small employer market. I should note very briefly that this is data that I'm using that is drawn from regulatory filings that insurers make in the case of the private market with state regulators. In the case of Medicaid, this is data reported by the states to the Centers for Medicare and Medicaid Services, which publishes it. That data is done periodically, though, in the case of the private market quarterly, in the case of the Medicaid data monthly, though the best and most comprehensive is on an annual basis. When you look at the experience that we've seen in the first 2 years, 2014 and 15, we saw a growth in the individual market from a base of 11.8 million people at the end of 2013. That was pre-ACA. We saw a growth to 17.7 million people in that market. In the employer coverage market, we saw two things. Fully insured, that is, plans where the employer buys the coverage as a group policy from an insurer. Fully insured employer coverage declined from 60 million to 53 million. At the same time, self-insured employer coverage, and those tend to be larger employers, grew by 4 million. The net of those three interactions on the private market was a net increase over 2 years of 2.3 million people with private market coverage. In comparison, over the period, you saw an increase from 60.9 million to 72.7 million in total Medicaid and CHIP enrollment. So what that leaves us with is a net growth of enrollment in those 2 years of 14 million, of which almost 84% was in Medicaid. Now, when we turn to 2016, we don't have full year data yet for either of these programs, but we do have some initial data for the first 3 quarters, and what we see is a growth of a further 842,000 people in the individual market, a further decline of 1.1 million in the fully insured employer group market, a further increase of 776,000 roughly in the employer self-insured market, and a further 2 million increase in Medicaid enrollment. Again, these are preliminary figures, but it looks like by the end of 2016, we can reasonably project that over the course of the 3-year period, health insurance enrollment will have expanded by about 16.5 million individuals, of which 13.8 million would be attributable to public coverage, Medicaid and CHIP, and the other 2.7 million to private coverage. What does all of this mean? In general, what it means is that the experience of the ACA appears to have had 3 significant effects. It has increased the number of people covered by individual market insurance, but a lot of that has been offset by a decline in employer-provided insurance, and it has principally produced enrollment increases through an expansion of public programs, particularly Medicaid, and particularly in those states that adopted the ACA expansion to able-bodied adults. I will be happy, Madam Chairman, to answer any questions the committee may have. Thank you.
Thank you, Mr. Haislmaier. Excuse me. We will now begin our question and answer session. I want to start by, first of all, again, thanking all the witnesses for being here and asking some questions. Let me begin by saying, as a nurse for over 40 years, what I am really concerned about, and as folks in my district call me and tell me the stories that are just so disheartening to me about their access to quality care and affordability, it really just bothers me terribly to know that there are some folks, as I said in my opening statements, that liked what they had and weren't able to keep it, in particular the high-risk patients in our state who were on a plan that the state had set up themselves, and people were happy about it. And in one day, 28,000 people with some pretty serious conditions were out of care. But let me also go to some statistics. Let me first of all talk about the costs, the rising costs, because we hear this every day in our office. 25% average increase in premiums this year for millions of Americans that are trapped on the exchanges. There was a lady in Tennessee who runs a daycare center, and she's on the exchanges, and her deductible went from $2,000 to $9,000 this last year. There's no way someone running a daycare business can afford that. $1 trillion in new taxes, mostly falling on families and job creators, have really hurt people in what they're able to do in their life besides just their health care. It really has hurt them. How about choice? Nearly 1/3 of the U.S. countries have only one insurer offering the exchange plans. In our state, 3/4 of our state only has one option. That's not choice, that's a monopoly. We also see 4.7 million Americans kicked off of their health care plans by Obamacare. And finally, I think you mentioned it, Ms. Turner, as the fact of the failed Obamacare co-ops. We had a co-op in our state that went belly up, and this is a cost to the taxpayers of $1.9 billion, not million, forcing many of these patients to try to find new insurance. And if I could have the staff pull up slide number 5, this is particularly disturbing to me because let's go back to the one with the hospitals, the 80, yeah, there. Hospitals who have been forced to close under the Obamacare, these are rural hospitals. 50% of my district is rural. If you can look at Tennessee, you will see a number of H's that hospitals who have closed in my district. Now, when that happens, if someone has an emergency, such as a heart attack, they're about 40 minutes from the closest hospital because their small rural hospital has closed. This is devastating to communities, not just for care that is provided, but also for recruiting businesses, because one of the things that new businesses will ask is, where's your health care? They want to know that there's health care in that community. So this has really been devastating, and I think that we can't discount these real stories that come to our office and just break my heart that that is what's occurring. So let me ask you, Mr. Haislmaier, Obamacare really focused almost exclusively on coverage. We saw that as they were pushing people into the computer to sign up for that, while neglecting the cost and the access of care. It was just, let's get as many people signed up as we can so we say that this program was successful. If health insurance doesn't cover the care you need, or if you can't afford the deductibles that come with your plan, or you don't have access, then isn't the number of people that are covered really meaningless?
Sorry, it's true that the authors of the legislation prioritized enrollment over cost control, which I think is one of the reasons the public was never sold on the bill, because most of the public wanted the reverse. They wanted cost control prioritized. In terms of the deductibles and in the coverage, the argument had been made indeed by advocates of this law that insurance with high deductibles was of less value. Some even called it junk insurance. The interesting thing is that that's what this law has produced. The reason for that is pretty straightforward. We saw that in other states that had adopted in the 90s similar measures, and that is when the law limits what dials the insurers can turn, they reach for the only dials that are left. So in this case, the only dials really left are to raise the deductibles as much as you can and or to limit the networks, and that's what we've seen progressing in the last several years in plan design in the exchanges, yes.
Ms. Turner, you talked about some of our young folks, and I know that there are about 20 million Americans who have said that Obamacare just isn't worth the cost. They've either paid the fine, which really is just almost funny to me, where the whole idea of this is to make sure everybody have coverage. And what's more important is now you're paying fines for something you're not even going to get coverage on. And then there are another group of people that filed an exemption. So we've got 20 million people out there who maybe would have had access to health care, potentially insurance, but now the cost of it is so high that they neither have the access to the health care nor do they have a dollar in their pocket because they're paying a fine. Could you talk a little bit about that?
Well, as you say, Madam Chairman, it does really go against the purpose of the law, and I know that many of the policy proposals that you and others have advocated would provide incentives for people to buy the coverage. And of course, the most important incentive is to make it more affordable. And one of the reasons that the coverage is so expensive is not only because of the 3-to-1 age rating ban that so disadvantages young people, but also because of the benefit requirements that are so much more generous than most people could afford. So I think those are two specific things to look at, in addition to the taxes that really go to the underlying cost mechanism of the law. So getting those costs down would provide the incentive for people to purchase coverage.
So I think it's interesting when we talk about 20 million, and that number moves all over the place, but let's just use 20 million, that 20 million people have received insurance. We look at the other side, there are 20 million people who have not received it that either are exempt or who have paid the penalty. I don't know that we need to hurt one group to help the other. I think that we probably can get to the place where we have a true patient-centered care and that we're helping everyone. I know, Dr. Book, I'm going to just leave you about 2.5 minutes, but as we prepare legislation in this area that truly is patient-centered reform, what's the biggest lesson from Obamacare experience that we can learn? And then if you have a second to tell us if there's anything that you think we ought to take from it that would also help us to make sure that we take out what's good.
I think the biggest thing to learn, thank you, I think the biggest thing to learn is that when Washington tells people what they need to buy, that might necessarily that does not necessarily make those people better off. One of the main reform I would suggest, though, one thing that we all want is not to exclude people, make it impossible for people with pre-existing conditions to get coverage. I myself had multiple pre-existing conditions when I left my previous employer and had to go and buy my own insurance, and this was before the ACA reforms took effect, and I had no problem getting insurance. I did have to pay for it, more than the average person, but I had no problem getting it, and that was under a law that was passed at least a decade before. On the other hand, now that Obamacare is in effect, I'm paying 2.5 times as much for my premium, and my deductible has gone from $2,400 to $7,000. My out-of-pocket is $13,000, and I'm one of those people that was supposed to be helped by the bill as a self-employed person who pays for his own insurance and has pre-existing conditions. I think we need to adjust the way we do subsidies. Right now, we subsidize insurance companies for covering people who have low incomes. And there's nothing necessarily wrong with that, but people with low incomes are not necessarily the same as people with health problems. Obviously, there's overlap, but they're not all that well correlated. I think we need to incentivize companies to cover people by who actually are, have adverse health status. We do that in the Medicare Advantage program using something called risk adjustment. There is a risk adjustment provision in the ACA, but it's completely different. It just moves money around between insurance companies without any reference to the health status compared to the underlying eligible population. If we did a risk adjustment that was based on the eligible population, I think we could solve the pre-existing condition problem without forcing insurers to charge more to everybody else. That would be my primary suggestion.
Thank you very much. I now recognize the ranking member from Kentucky, Mr. Yarmouth, for any questions.
Thank you, Madam Chairman. Thank you all for your testimony. It occurs to me that what we've basically just heard in the aggregate is our biggest complaint and observation about this debate in recent weeks and months. And that is, we spent a lot of time hearing about the problems with the ACA and very little hearing about the alternatives. I'm going to characterize all the testimony. Now, Dr. Blumberg gave a number of suggestions. By the way, I would say, Dr. Blumberg, every one of those could be implemented by this Congress acting. Eliminating the employer mandate, for instance, could be done by this Congress. There's been no suggestion from the Republican side of doing that. And that's kind of where we've been over the last 6 or 7 years, is that while we've seen problems arise, Republicans have been unwilling to address problems. Instead, they've just said, let's repeal it, and they've done that 65 times in the House. But anyway, Ms. Turner, in your testimony, I guess you could infer that you would recommend doing away with the employer mandate, since you said that was a problem, but beyond that, you really don't offer any solutions. Dr. Book had 7 pages of criticism of the ACA and identifying problems, and then 3 paragraphs of solutions, one of which is two provisions to be repealed, and then mentioning the question of the high-risk population, which, I don't know, I would characterize it as just another form of a high-risk pool. You just change the mechanism for financing, government financing of high-risk patients. And Mr. Haislmaier had no particular recommendations, which probably makes sense since the Heritage Foundation was the originator of the idea of the Affordable Care Act, much of it. So this is why we are so frustrated, because this Congress and this president have said, we're going to repeal it. That's first priority. And really, there are no ideas for replacing it. Now, I have my opinion about that, and I've said it many times. There are only, in my opinion, only two alternatives to the Affordable Care Act. One is to go back to where we were, where insurance companies decided who lived and died, and single payer, Medicare for everyone. The other solutions that have all been proposed are just tweaks of the Affordable Care Act. And that's why we keep saying there is no plan. There are ideas. Health savings accounts, that's an idea. Selling insurance across state lines is an idea. It's also allowed under the Affordable Care Act. But this is not a plan. So that's, again, a lot of my frustration. But I'm also frustrated about the way we talk about this and debate it, because, you know, we all have anecdotes. I mentioned an anecdote in my opening statement. The chairman has mentioned anecdotes. In my state, which has probably done the best job of expanding Medicaid of any state in the country, we've reduced the uninsured population by 60%. 440,000 people signed up for Medicaid as part of the expansion. And yes, some of them probably would have qualified before, but not all of them by any stretch. We don't have any complaints about access to providers. As a matter of fact, if you look at virtually every category of care, preventive health, screenings, dental visits, vision visits, just about every one you can mention, we've had a more than 100% increase in that activity in our state. So our state's getting a lot healthier. It's also kind of frustrating, and here where we tend to get in the weeds a lot, but we hear this statistic all the time. 1/3 of the counties in the United States have one provider. I would say 1/3 of the counties in the United States don't have enough people to support more than one provider. I mean, that has to be a factor in that statistic. But again, it sounds pretty doom and gloom. The chairman mentioned 80 rural hospitals closing since 2010. We passed the Affordable Care Act in 2010. I'd be interested in knowing how many of those hospitals have closed in the last 2 or 3 years. Because in my state of Kentucky, what we've heard is that rural hospitals have been saved by the ACA. As a matter of fact, we had a hospital in Moorhead, Kentucky, not in my district, which was on the verge of bankruptcy because of the ACA and because the population that was that hospital service was largely a very, very poor and unhealthy population. Now they're getting compensated for the care they were not compensated for, and they've now built a big professional office building. The hospital's doing fine, and we hear that story time after time. So, you know, again, we can all cite anecdotal situations that support our point of view, but we need to be balanced in that. So I have a question, Dr. Blumberg. You know, several of the replacement plans that we've heard about, Dr. Price's and several others, seem to be at least focused on certain common elements, and one of them is a tax credit. In Dr. Price's plan, for instance, it provides tax, so you can go out and buy insurance, that provides tax credits that vary only by age, and it goes from $900 to $3,000 per person. Do you have any idea what kind of coverage in today's market you could buy for $900 to $3,000 a person?
Well, we have recently done some estimates. What the goal was to construct a package. We assumed 5-to-1 age rating, as many of those looking for replacements are leaning that direction with the age rating. We tried to construct a package that would allow an individual of any age, so any adult from 18 to 64, to buy a particular package with the tax credit that was offered under the price plan by the different age categories. The plan that the most generous plan that we were able to construct that brought in everybody of those ages with that amount of money was a plan that would require the individuals to spend the first $25,000 in health expenses. So a $25,000 deductible for a single, $50,000 for a family. We found that we had to take out coverage for drugs that were not generic, so only generics covered, so that excludes chemotherapy drugs, it excludes insulin. Those are not generics, a number of other expensive drugs for chronic illnesses. We had to exclude coverage for outpatient mental health and substance use disorder treatment. We had to exclude physical therapy, occupational therapy, speech therapy, and rehabilitation care. Now, you could structure this somewhat differently, but you're bound and constrained by the math. So you could provide some coverage up front and then far less at the back end. You could fill a little bit with which of the benefits that we included or excluded, but you're quite constrained by the amount of money.
So let me get you to repeat that. We'd be talking about $25,000 per insured in deductibles, $50,000 for a family, and the elimination of a substantial amount of the coverage that a policy under the Affordable Care Act would provide.
That's correct.
Appreciate that. One thing, while we're on the subject of costs, that I think we need to mention is that while costs have gone up, and costs, by the way, when the year before we passed the Affordable Care Act, I think insurance policies across the country, rates were going up 38%. I know they were in California, they were in Kentucky, they were in Connecticut. That was a strange number, but that 38% seemed to occur in a lot of places. After the Affordable Care Act has now been in effect for 5 or 6 years, we've seen the lowest rate of growth in insurance costs and in Medicare expenditures and in Medicaid that we've seen in modern history. Medicare, I think, is down to about 2% annual growth. Private insurance is around the 2% level. So while, yes, costs are still going up in the system, the improvement has been rather dramatic. Is that your assessment as well, Dr. Blumberg?
Yes, what we know is that per capita spending in national health expenditures has grown much more slowly than had been anticipated prior to implementation of the Affordable Care Act. Certainly some of that is attributable to the act itself, and some of it is from other economic and structural changes, but that certainly is the case.
Right. And finally, well, I think it's interesting that several of you said that the ACA focused exclusively on, or largely on, coverage, which was certainly one of our goals. But the changes that were made in, again, with protections for people who already have insurance, the changes in annual and lifetime limits, the removal of those limits, allowing young people to stay on their parents' insurance policy until 26, these had nothing to do with people who didn't have coverage. This was people who already had coverage, and also the improvements we made in Medicare, reducing the cost of prescription drugs in Medicare, getting free preventive care, annual wellness visits. So there were a lot of improvements that have been made for patients who already had care one way or another. Unfortunately, we didn't talk about them, and that's the main reason I think that the Affordable Care Act has not been as popular over the last few years as it otherwise would be. Thank you very much, Madam Chairman, and I yield back.
I thank the ranking member. I do feel that I do need to make a statement here when we talk about these scenarios, that we talk about anecdotal scenarios. These are real people. 28,000 people in my state who were sick, people that were in a risk pool that liked it, lost their insurance in one day because it did not meet all the criteria that Washington said it needed to meet. I want to tell you, before I came here last week, I got a call from one of my constituents who has lupus. She lost her insurance when that day occurred. She is now on the exchanges. She is unable to use the doctor that she's used for years to control her lupus. There is only one provider of the insurance company in her area. So now she lost her doctor. She cannot take the same medication that she was taking previously that helped control her condition for years. And now her costs have gone up to the point where she said, I've got to pay it. I can't do anything else, or I'm not going to be able to function. And so these are very real faces that we're talking about. These are not stories that are made up. These are very real lives, and we have got to change that so that people can have their lives. With that, Mr. McClintock from California, you're recognized for 5 minutes.
Thank you, Madam Chairman. The thing about Obamacare is you really can't spin it one way or the other, to a greater or lesser extent. Every family in America has had an up-close and personal experience with it. And I think any politician that tries to convince them that their experience is different than what they know is going to look downright foolish. The polls tell us most Americans don't like it. This was a prominent issue in the last 3 congressional elections in which the Democrats lost a net of 67 U.S. House seats. This Congress has a mandate to deal with it, to relieve families of its burdens, to fix the underlying issues that spawned it, and restore what was once the finest health care system in the world. The concern, and there are basically 2 options we have. One is to repeal it in its entirety and immediately replace it with the patient-centered free market reforms that the chairwoman referenced earlier. Restore to people the freedom to choose a plan that best meets their own family's needs from a vast market that's competing with each other to provide better services at lower prices, and to, through the tax system, assure that every family has at least a basic plan within their financial reach. That's one option. There's another option that we seem to be pursuing, and this is what I want to drill down on in my questions, and that is to repeal parts of Obamacare through reconciliation and through administrative action, and then rely on follow-up legislation to finish the job. Because reconciliation can bypass the 60-vote cloture rule in the Senate. The follow-up legislation cannot. And that leads me to wonder, what is the market going to look like if Senate Democrats decide not to cooperate on the post-reconciliation fix? So I would like to ask a series of yes-no questions of Dr. Blumberg and Mr. Haislmaier to see where the 2 sides agree and where they don't. Can reconciliation end the Obamacare subsidies and replace them with tax credits? Dr. Blumberg, yes or no?
I know it can repeal the subsidies. I'm not
Okay,
clear on
Mr.
the text
Haislmaier?
replacing it.
I believe so, but
Okay,
believe
so
so.
we generally agree on that. Can it zero out the taxes and the tax penalties that's used to enforce the individual mandate?
That is my understanding, yes.
Mr. Haislmaier?
mine as well.
Can it end the non-compliance penalties on businesses and return Medicaid to its pre-Obamacare condition?
I believe that's the case, yes.
Mr. Haislmaier?
I believe so, yes.
Okay, now, HHS does have some latitude in redefining the mandates, does it not? Dr. Blumberg?
There is some latitude.
Right.
Yes.
Mr. Haislmaier?
HHS does have latitude, yeah.
Okay, is the HHS, though, still required to provide guidance consistent with benefits found in a typical policy? Dr. Blumberg?
I'm not sure I understand that question. Can you ask it again?
Doesn't the underlying bill or underlying law require that the essential benefits match those found in a, quote, typical policy?
That's right. There's some
Okay,
state
Mr. Haislmaier?
flexibility on that.
They have such categories of benefits, and within that is HHS would have
Is
to work.
HHS still bound by the Administrative Procedures Act that forbids actions that are arbitrary or capricious?
I'm not familiar with that, so I can't answer.
Yes.
Mr. Haislmaier?
Yes.
Can reconciliation repeal the underlying law? Dr. Blumberg?
I don't think reconciliation can
Mis-
repeal all the components of the
Mr.
law. no.
Haislmaier?
That's my understanding of Senate procedure as well.
Okay, will non-compliant policies then still be illegal? Whether it's being enforced or not, will they still be illegal?
Non-compliant plans aren't illegal today, sir. There are many of them being sold. That's one of the problems in the state of Arizona and why their premiums have gone up so much, is there's lots of non-compliant plans being sold.
Mr. Haislmaier?
Yeah, there are non-compliant plans that are legal and will remain so.
Okay, now, is this because state governments are still the principal enforcement mechanism for Obamacare?
It's because the Affordable Care Act regulated a certain category of non-group insurance coverage, but not those that remained outside. So plans like plans that don't cover you for an entire year are non-compliant plans. and
Mr.
are out
Haislmaier?
there.
Yeah, there's certain underlying types of coverage that are exempt from the ACA.
In a post-reconciliation world, do state governments still have to approve any new plans? Dr. Blumberg?
Right, the Department of Insurance and Estate
Haislmaier?
regulates what's offered there.
That's a matter of state law.
Okay,
yes.
now the final question, kind of, and this you can elaborate on, but you got about 5 seconds each to do it, and that is, in this post-reconciliation market then, do we run the risk of adverse selection being accelerated and and states refusing to approve non-compliant plans, or insurance companies refusing to issue them?
There's a definite risk that non-group markets in general for comprehensive coverage and other types of coverage most people like to purchase in the non-group market would utterly collapse.
Mr. Haislmaier?
There is a slight risk of making the current adverse selection in the market marginally worse. There are things that HHS administratively can do to marginally decrease the adverse selection that is already occurring. So on balance, it may be about where we are right
The
now.
gentleman's time has expired. The gentleman from New York, Mr. Higgins, is recognized for 5 minutes.
Thank you, Madam Chair. Now that the Affordable Care Act has been taken out of a political context, at least in terms of the calendar, it needs to be dealt with in a legislative context, and facts are very important in that regard. Medicare is where 55 million Americans get their health care. It costs $600 billion a year. It's 15% of the federal budget. Before the enactment of Medicare in 1965, more than half of the senior citizens in this country did not have health insurance. The reason being is that for-profit insurance companies didn't want to write a policy for people that were sick and therefore costly. So the American government had responded by establishing a Medicare program. So we went from 56% of American seniors without health care to today, 97% do have health care because of that program. But the cost of that program was not sustainable because between 1970 and 2010, Medicare per person cost grew at an annual rate of 7.5%, about 4 times the rate of inflation. It was breaking businesses, it was breaking individuals, and the number of individuals that were filing for bankruptcy protection soared because of this. Today, because of the Affordable Care Act, annual per person growth is at 1.4%, fully 6% less than it was prior to the enactment of the Affordable Care Act. And Medicare costs are lower per person today by over $1,300 per person than they were in 2010. So when we set out to do health care reform, there were 2 objectives. One was to increase the number of people that didn't have insurance, individual mandate. Why? Because the insurance model only works in health care if you have healthy payers who are paying for the cost of those that need it later in life. Analogous, some people say, to car insurance. So 20 million more people have health insurance today. So that's a success. The other objective was bending the cost curve, as economists would call it, basically trying to reduce the annual growth of healthcare so that it doesn't exceed the rate of inflation. Because if it does, eventually businesses go broke and individuals go broke. That's just how it works. So I think on those 2 counts, the Affordable Care Act has been a very positive thing. And before we consider repealing it or obliterating it, we ought to have an alternative that is constructive and based on fact. The individual mandate, again, a hallmark of healthcare reform. And the idea, again, is to ensure that you have healthy payers that are paying into the system to pay for the cost of those who are older and need health care. Mr. Haislmaier, how long have you been at Heritage?
that's a trick question because I left and came back, but I've been associated with it for about 30 years, of which
30
I've been there
years.
about 15.
So you were there in 1989.
Yes.
Did you contribute to a report that was sponsored by Heritage called A National Health System for America?
Yes.
And you collaborated with Stuart Butler?
Yes.
Okay. In that report, Mr. Butler said that many states now require passengers in automobiles to wear seatbelts for their own protection. Many others require anybody driving a car to have liability insurance. But neither the federal government nor state requires all households to protect themselves from the potentially catastrophic costs of serious illness. Under the Heritage Plan, there would be such a requirement. That was the basis for the individual mandate. Do you still believe that the individual mandate should be a part of the healthcare system in America?
Well, it depends on how you define an individual mandate.
I think it's pretty clear here, sir.
Well, no, it's not, because you're assuming that it's a pay mandate. So when we actually helped draft legislation, which we did in '93 with the Nichols-Stearns bill, we said that, look, if you didn't have health insurance, then you couldn't qualify for, or you would lose your your personal exemption on the tax code. Now, one might be able to characterize that as a mandate, but that's very different than the design in the ACA, which says buy a plan or we fine you. So,
Well, coming back my time, because my time has expired, I would just say for the record that it's pretty clear here, the origins of the individual mandate and the sound reasoning behind it, and that was embraced
The gentleman's
as a
time has
major
expired.
piece of the Affordable Care Act.
The
I'll
gentleman from
yield back.
Georgia.
Thank you.
The gentleman from Georgia, Mr. Woodall, is recognized for 5 minutes.
Thank you, Madam Chair. I'm pleased to be back with you on the Budget Committee this cycle, but I will tell you that if we reclaim time that has already expired, then we see what the problems are we're going to face.
That's
We're
right.
trying to balance this
Thank
budget
you.
going forward. I'm glad you all are here. And Dr. Blumberg, I'm particularly appreciate the solutions that you added to the end of your testimony, because I do think there's so much that we can do together. Mr. Haislmaier, I asked you how long you'd been associated here. I was a staffer on the Hill when it was led by the great bipartisan Newt Gingrich from the state of Georgia. And of course, in those good bipartisan times, we passed health care reform. We abolished pre-existing conditions for every single health care plan that the federal government had jurisdiction over, every single one. You may think that that got jammed through with reconciliation. I happen to have those conference report numbers here. There was a conference report with that bill at that time, abolishing pre-existing conditions. The vote in the Senate was 98-0. And the vote in the House was 421-2, with one of those great opponents of health care reform, Pete Stark, voting no at that time. Of course, Pete voted no because it didn't go far enough, not because it got that done. And I contrast that with what's going on right here. You suggested, Dr. Blumberg, that if we repealed the ACA today, that we would be worse off than if the ACA had never passed. I want to stipulate I believe that to be true. I think we have wasted so much time of fighting about this that we could have dedicated to real fundamental reform. You know how much time we've spent arguing about repealing pre-existing conditions in the federal health care market since 1996? Zero. And people are benefiting from it. We're wasting time and money here, and a repeal would not get that back. I think we've also threatened some of the underlying economics of the plan. I want to point to Mr. Haislmaier's testimony. He says this: reading glasses have come about since we've been fighting about the Affordable Care Act too. He says, in general, enrollment data indicates that implementation of the ACA appears to have had 3 effects on health insurance coverage: an increase in individual market enrollment, an offsetting decline in the fully insured employer group plan enrollment, and a significant increase in Medicaid enrollment. Does anyone dispute Dr. Blumberg?
Yes, I dispute his findings of his study.
You believe that we have not seen an increase in Medicaid?
No, I know we've had an increase in Medicaid.
Do you
and
believe we have not seen a decrease in employer
Absolutely
coverage?
not. We have not seen any measurable decrease in employer-sponsored insurance, and we see that in multiple nationally representative surveys, both of employers and of households. Employer-sponsored insurance has remained incredibly stable since the implementation of the act.
The truth is, if you're going to spend $1 trillion on a program, it's really not surprising that we can tell stories of folks who have benefited. And I'm glad, I say that sincerely, I'm glad for folks who have found a benefit out of $1 trillion worth of taxpayer money. What's shocking is that we can spend $1 trillion and find folks who are worse off today than they would have been before. And the small groups that I experience in my district, those small family businesses that went out of their way to buy a more expensive plan because one secretary in that office had a special needs child and the entire office wanted to collaborate in order to get that child the plan that they needed, the care that they needed. And those days are behind us now. Those plans have gone away. That employer can't afford to do that anymore because he's lost the choice in that marketplace. I think about the work that Ms. Turner has done. Yes, 75% higher rates for young people for a corresponding 12% decrease for 64-year-olds. And when those young people act based on their own economic self-interest, shocking that people still do that, but they do, then we see those elderly folks, those 64 and under folks, disadvantaged in ways that they would not have been pre the Affordable Care Act. It encourages me that I can read Ms. Turner's testimony and I can read Dr. Blumberg's testimony, and I can see that we all agree that those three bands have failed. We all agree that that pricing structure has failed, and it can be on the short list of things that we begin to collaborate on. 421 to 2, 98 to 0, Republicans in the House, Democrats in the House, Republicans in the Senate, Democrats in the Senate, and Bill Clinton in the White House got this done. And shame on us for having started down this road. I hope we can do better in fixing it. I yield back.
The gentleman's time has expired. The gentlelady from Washington, Ms. Delbany, is recognized for 5 minutes.
Thank you, Chairman Black, and thanks to all our witnesses for being here with us today. If you knew nothing else about the Affordable Care Act, all you'd need to do is read the title of today's hearing to understand that it's brazenly partisan. The majority wants to talk about the effects of the ACA, so let's talk about them. One effect is that people don't go bankrupt when they get sick anymore. That sounds like a pretty good outcome to me. More than 120 million Americans with pre-existing conditions are no longer denied coverage. Young adults can stay on their parents' plans till they're 26. And over 10 million seniors have received help with their prescription drug payments. And all insurance plans are required to cover preventative services at no cost. This is especially critical for women. Each year, this helps 55 million women save more than $1.4 billion on birth control. Many of my friends from across the aisle have said they want to keep the good parts and just get rid of the bad. So what are we really doing here? For years, my colleagues and I have offered proposals to strengthen the ACA, and were turned away each time. I have a bill to make it easier for small businesses to provide coverage for their workers, for instance, and yet folks don't want to talk about that. They just want to talk about repeal. So now we know the effects of the ACA, which is the purpose of the hearing today. So let's talk about the effects of repeal. You're going to hear a lot of numbers thrown around today, and it's easy to get lost in the statistics and forget that this is about people. What's important to remember is repealing the ACA hurts real people across the country in profound ways. It means taking away health coverage for 30 million Americans. It means seniors will have to pay more for critical prescription drugs. And it means women will once again be denied coverage simply for being a woman. It also means a great deal to people like Sue Black. Sue is a public school teacher from my district who was diagnosed with stage 4 ovarian cancer at the age of 47. 5 years later, she received a short but terrifying letter from her insurance company. In 4 sentences, it said she had exhausted 3/4 of her lifetime benefit limit. Thankfully, the Affordable Care Act banned lifetime caps on coverage. And she's not the only one. In the past few weeks, my office has been flooded with stories from constituents describing how the Affordable Care Act saved their life or the lives of their loved ones. And meanwhile, the Republican plan for health care in America is repeal the Affordable Care Act and then just trust us. I think our constituents deserve better than to have their health coverage taken away with no plan for what comes next. Ms. Blumberg, I wondered, in your opinion, is there a segment of the population that would benefit from repealing the Affordable Care Act without a replacement plan in place?
You know, folks who do not want to purchase health insurance coverage and are subject to a mandate penalty as a consequence of the act, under that sort of repeal through reconciliation, they would have less penalty to pay. The problem is that there would be such a huge loss of insurance coverage for a much larger percentage of the population. The uncompensated care burdens would increase so much on healthcare providers and on state governments that I think that would be far outweighed. Otherwise, I can't really come up with people who are going to be benefiting as a consequence.
And can you describe the effects on children if the Affordable Care Act were repealed?
By our estimates, roughly 4 million children would lose health insurance coverage. Some of these children are covered with their families through the marketplaces with financial assistance. Others will lose their coverage because what we know from a lot of experience with the Medicaid system and with the ACA is that when adults know that they can have assistance in getting coverage, they find out when they go to enroll that their children are eligible for CHIP as well. And so if the parents know they can't get care coverage and they don't go seeking it, then their children won't end up getting insured as well.
Thank you. And we keep hearing from my colleagues on the other side of the aisle how the Affordable Care Act is going to collapse. But hasn't enrollment been growing, especially right now? And isn't the real threat right now the promise of repeal?
Absolutely. The repeal without replacement is a recipe for a death spiral. And right now, the Affordable Care Act, as I said, has some areas in which there has been high premiums and that we have some policy strategies that should be put in place to address them. But by and large, it's being successful at increasing coverage, increasing access, and improving affordability.
Thank you. I yield back, Madam Chair.
The gentlelady's time has expired. The gentleman from Alabama, Mr. Palmer, is recognized for 5 minutes.
Thank you, Madam Chairman. I just want to share some information that I've got from some of my constituents. As a doctor, sent me some information that that he saw a patient last week whose deductible was $9,000. Essentially, her insurance is basically catastrophic insurance. She probably has 2 patients a month who cannot schedule surgery or schedule when or they schedule and then cancel the surgery, and basically, because people cannot afford the deductibles, they're not getting the health care that they need. It's impacting the quality of life, impacting their health. Here's another family that's gone through 3 or 4 different plans. Their premiums went from about $1,400 for a family of 4 to $2,100. When they take the out-of-network, their deductible is $13,700. Madam Chairman, the Affordable Care Act is an oxymoron. There's still over 28 million people who don't have health insurance, and most of them, according to the Kaiser Foundation, say it's because they can't afford it. So you've basically put one group into the Affordable Care Act, most of them are Medicaid. You've displaced people who had employer-provided plans. I think there's about 8 million of those. You've caused companies to not expand. I've got information here from companies where they wouldn't hire that 50th employee. And as a matter of fact, one of these had 45 employees. They've cut back to 32 because of the premiums that they have to pay to provide health insurance for their employees. And Madam Chairman, it's had a terrible impact on employment. I don't know if our friends across the aisle are aware of this, but there's over 94 million able-bodied Americans who are out of the workforce, the highest number I think ever for the country. Prior to 2008, there were 100,000 more businesses starting up than were closing. These are mostly small businesses. According to a report from Gallup, as of 2014, there are now 70,000 more businesses closing than starting up. You have people who had full-time jobs with good wages and health benefits that have been cut back to part-time. They're now having to work 2 part-time jobs at lower wages with no health insurance. You know, the best thing that I can say about the Affordable Care Act is that we now know what doesn't work. And I'm confident that we can move forward with plans to replace it. Ms. Turner, you've worked in this area for years. We know, I think, goes all the way back to the 90s that you've been involved in healthcare reform. Are you confident that we can repeal this and replace it with something that we don't put millions of people out of the insurance market? We allow people to actually choose their doctor, choose their health insurance. Do you think we can do that?
Absolutely, and I agree with you, Mr. Palmer, that we have learned a lot about what does not work with this law, and I think that is a good foundation to figure out what we can do. And I know that many members actually have real legislation on both sides of the aisle, and certainly the House spent a great deal of time developing the Better Way plan that the chairman talked about. There are good ideas out there. They involve putting patients at the center, returning power to the states to be able, and resources to the states to better organize their health insurance markets to be more responsive. But yes, I'm highly confident. Everybody talks about repeal and replace, not just repeal.
Dr. Book, you brought up the fact that life expectancy declined this past year for the first time in over 2 decades. Are you, I think, what was it, 12 or 13 million people were put into Medicaid that gets counted among the number of people who received health care insurance. Are you aware of the studies that show that people who are on Medicaid have poorer health outcomes, treatment outcomes, than if they had no insurance at all? Are you familiar with that? Can you comment on that?
Yes, I'm familiar with that. There are multiple studies showing that people on Medicaid have worse health outcomes than people who are uninsured. It's unclear whether, it's hard to argue that Medicaid actually makes people sicker, but it's possible that people who are uninsured are either able to pay their own bills, able to obtain charity care, or perhaps are simply healthier to begin with. But certainly Medicaid does not have a very good record in terms of restoring people to health, making people live longer. People with Medicaid use emergency rooms more than the uninsured and more than people with insurance, and they have worse health outcomes than any other group.
The gentleman's time has expired.
Thank you, Madam Chairman.
The gentleman from California, Mr. Khanna, is now recognized for 5 minutes.
Thank you, Madam Chair, and thank you, Ranking Member Yarmouth, for your leadership. It's an honor to be on this committee. Ms. Turner, on April 8th, 2016, you were quoted in the New York Times as describing President Trump's proposals as, quote, sketchy and inadequate. You went on to say, and I quote, he has to flesh out his proposals with much more detail if he hopes to persuade voters that he has a credible plan to replace Obamacare. Do you remember saying that?
Yes, sir.
Do you still believe that?
That was a very early preliminary list of 7 points that he issued during the primary season.
Do you believe he has now articulated a comprehensive plan?
He is working with members of Congress, as I think is really very appropriate, and looking forward to.
Can you point to any specific changes that he has offered now different from your statement in April?
Yes, he gave a major speech in Pennsylvania on November the 1st and outlined a very different and visionary kind of approach to
What
health reform.
specifically?
Would return much more power to the states, deregulate the market, give people many more choices of coverage that
I
they
thought
can
he has been
afford.
saying that since he announced. Was there any specific changes he has offered since your statement in April?
He has been, he is working with members of Congress. He does not do, as I think the Obama administration made
Okay,
the
if I
mistake
can
of doing.
move on. President Trump also had called for removing barriers to imported drugs from other countries, same as, by the way, Senator Sanders. Now, you're opposed to the president's policy on that, correct?
I believe that there is a great risk to the American people of imported drugs that we do not know
So you
the
disagree
origin.
with President Trump when it comes to imported drugs?
Yes.
and you disagree with Bernie Sanders, and you're on the opposite end of what President Trump is proposing in that. Is that correct?
I think that there are legitimate safety concerns that the federal government, including former FDA Commissioner Mark McClellan,
I appreciate that. I just want to be clear that you're on the, you disagree with President Trump when it comes to that.
Yes.
And your op-eds consistently, as you disclose, to your credit, say that your organization is funded by the pharmaceutical industry. Is that correct?
No, that's not correct.
I've-
We receive some funding from the pharmaceutical industry, but we've brought broad funding from individuals inside and outside
I
the
respect
health
that,
sector.
but on all the op-eds, it says you're partly funded from pharmaceutical industries. In your own McClatchy
And so
editorials?
is virtually every person in a think tank has some funding from pharmaceutical companies because they believe in
Could you
innovation
disclose
as
to
we
this
do.
committee which pharmaceutical companies fund your organization and how much money you receive from them?
Those, that list is really proprietary information. It's basically how we have special relationships with all of our donors inside
Ms.
and
Turner,
outside the
with
health
due
sector.
respect, when I have to disclose every financial interest I have, my spouse has, because if I'm going to articulate a viewpoint on something, the public has a right to know what financial interests I have. I would suggest if you're giving testimony to the United States Congress that the public should have a right to know what financial interests your organization has.
We disclose those on our 990 form that we file with the Internal Revenue Service every year. The Congress has seen fit to allow the lists of donors to remain private as proprietary information because it's basically our intellectual property. How do we get our funding?
So you are unwilling to disclose which pharmaceutical industries companies are funding your organization or how much money you receive from them?
It would be unfair to them because we receive funding from many other organizations, a great majority outside the pharmaceutical industry.
So the pharmaceutical funding is less than the majority?
Oh,
Mr. Khanna,
absolutely.
that really is not the purpose of this hearing. I think the witness has already answered that she is following the law. If you would like to ask another question, I think we ought to stay on the topic of what we came here to do.
Well, Madam Chair, I think that the issue where the President has said that he is for the importation of drugs, and that's an important point in this debate on health care, the witness is offering an opinion that is in opposition to the President of the United States, and I'm trying to understand why she believes what she believes, and if there are financial interests that may be coloring her opinion.
Mr. Khanna, I think the witness has again answered that she is following the law. Now, if there's a part of this that you would like to change the law, you certainly have the authority to be able to offer a bill.
I see my time has expired.
Thank you. The gentleman from South Carolina, Mr. Sanford, is recognized for 5 minutes.
Yeah, given the last interchange, I think we should all be careful about judging each other's intent. I could list a long list of left-leaning organizations that don't disclose their funding sources. There are groups on the right. I think we need to be careful about that. And in that regard, I would give credit to my Democratic colleagues for what they have tried to do with Obamacare. I think that if you look at the actual intent of Obamacare, it was good. The idea was to help people with pre-existing conditions, to look at how you deal with this. I remember there was a great movie years ago. Helen Hunt was in it, and I cannot remember the name of the movie to save the life of me. But there was a great tagline, and I remember this is back at the time that insurance companies were declining people, and she said something to the effect of, well, my insurance company declined me, and the audience in the movie theater that I was in, I mean, they went nuts. I mean, the people literally started clapping spontaneously. So I think that the intent of Obamacare was good. It was how do we get our arms around this problem? The question has been in implementation. I think that that's what a lot of us struggle with from the Republican side, and I suspect many independents and Democrats as well. And with that said, I guess I'd say a couple of different things. You know, I think fundamentally we all recognize the fact that the marketplace likes a product that somebody else pays for. That in the history of mankind, there is almost unlimited demand for a product, in fact, that somebody else is paying for. And it has, to a degree, part of that fatal flaw built into it. I think that we have to recognize that the math certainly shows it, that sick people cost more than healthy people. And, you know, the fundamental problem of healthcare in general is it's almost an 80-20 phenomenon, that we're in 80% of the 20% of the folks are costing about 80% of what we deal with in healthcare. That's from the right or from the left. And as we age, we cost more. I mean, my sons are immortal, or pretty closely so. And as you look at large pools of population, those trends hold true, notwithstanding horrible illnesses that happen to young people. And what we've come up with in construct with Obamacare is we're going to stick the young people with the bill. In essence, it's fundamentally flawed. This 3-to-1 ratio is mathematically incorrect, and there's some math built into this equation that just doesn't work. And so a number of us are saying, okay, the intent was good, but practically speaking, where do we go from here, given the fatal flaws that are built into it mathematically? To my colleague, Mr. Palmer's point, if you look at some of the outcomes, and I dealt with this for 8 years when I was governor, as we were dealing with Medicaid, there's just some fundamental flaws. We have a disease treatment program, but we don't have much in the way of prevention. And so I think we're all struggling with where do we go from here. Is there a different way of dealing with pre-existing condition and high-risk pools and all the things that are talked about that perhaps you've seen it in a different country or something that really has worked well within an individual county or state? I just, in the minute and 35 seconds that are left, I'd be curious to hear any of your thoughts in terms of best practices that we can borrow as we all collectively struggle with this debate before us. Yes, ma'am.
I would say that, you know, almost all industrialized countries have a single payer type system where I agree with you. The fundamental problem with doing reform is this skewness of the distribution of health expenses. And so how do you share those expenses? And I think, you know, obviously all the foreign single payer plans spread those costs broadly through the taxpayer system. And, you know, here we're not in that place to be doing that. But I think, you know, we don't want to criticize the 3-to-1 age rating without recognizing that without a different mechanism, the people who are older adults who have more health problems wouldn't be able to afford their coverage if we went to, I mean, I used to see 11-to-1 rating from some insurers in the old days. So, yeah.
I see I've got 30 seconds. I'm
Okay.
going to reclaim it. It just seems to me on that very point that you raised, and it's a legitimate point in terms of industrialized countries around the globe, that you've got 3 variables within healthcare, though. You've got access, you got cost, and you got quality. And in as much as many of those countries have been able to spread access, it's been to the detriment of quality and cost. And so people don't go to Britain to do certain procedures. You're literally on a death list in Britain. And I think that those kind of societal questions are part of what we are struggling with. I'm going to hand off to your colleague. Go in the second you've got.
In 5 seconds, a lot of those single payer countries have annual and lifetime limits on the services they can provide to a person, and they have much higher death rates from serious diseases like cancer because they just don't treat them.
The gentlelady from Washington, Ms. Jaya Paul, is recognized for 5 minutes.
Thank you, Madam Chair. As this is my first hearing on the House Budget Committee, I just wanted to express my great appreciation to you and to our ranking member, Mr. Yarmouth, for your leadership and guidance, and I'm looking forward to working with everyone on the committee. Madam Chair, last week over 2,000 people joined me in Seattle in support of the Affordable Care Act and demanded that it not be repealed without a replacement and that we in fact focus on expansion. I heard from many who are seriously terrified that their health care will not only be stripped away, but that there is no replacement. Sally is a single 80-year-old woman who told me that she would be severely affected if her Medicare benefits were cut. She worked for 30 years, was healthy, until 3 years ago when she was diagnosed with a serious cancer. Medicare benefits covered much of her hospital and treatment costs, which she could not have paid for on her own. She said, if Medicare is cut or reduced, I will be struggling to keep up with healthcare costs. Madam Chair, I agree with you that this is about real people, and this is just one story. I've heard hundreds. I would like us to consider the big picture. In the state of Washington, my home state, A repeal of the ACA would mean 750,000 people would lose their health care. Almost 3 million people in Washington state with pre-existing conditions would not be guaranteed coverage anymore. And speaking of pre-existing conditions, being a woman would once again be one of those pre-existing conditions, as we would have to pay out of pocket for cancer screening, Pap tests, and birth control. Our state benefited greatly from Medicaid expansion. 605,000 people gained coverage and would once again be without health care. And 55,000 young people in Washington state who are barely getting by would once again be kicked off of their parents' health insurance. There are no winners with an Affordable Care Act repeal, Madam Chair, and that's why I hope that forums like this can be focused on what we can do to make it better, but a replacement plan, which has not been offered, instead of nothing. I wanted to say I come from the state Senate, which is controlled by Republicans, and the chair of the Healthcare Committee in the Washington State Senate, Senator Randy Becker, recently said this is not a partisan issue, this is a bipartisan issue. She believes that any replacement should build or improve the reach of Medicaid expansion funds. In Washington, this represents about $3 billion and the majority of the funding received under the ACA. So Dr. Blumberg, can you speak to specifically Medicaid expansion and the states across the country who have benefited from Medicaid expansion?
Sure. There's been a big infusion of federal dollars into the states that expanded Medicaid, allowing them to make all individuals, regardless of their family situations, eligible up to 138% of the poverty level for the first time. This has done a lot to improve the financial situations of hospitals in those states relative to the states that did not expand. As my colleague Fred Blavin has shown in a recent JAMA article, this is big financial benefits. In addition, these are comprehensive benefits with no cost sharing, so it makes coverage, access to care incredibly affordable for the low-income population.
Thank you. I appreciated the concern for fairness throughout everybody's statements, and so but I'm trying to understand exactly what you do believe should be covered and some of the provisions of the Affordable Care Act. So just yes or no answers, if you would, for all of our testifiers. Do you believe that young adults should be able to stay on their parents' plan until they are 26?
As long as the $1,200
Just
cost
a yes
per
or no, Ms.
worker
Turner. Thank
is
you.
visible.
Was that a yes?
If they want to pay for it.
So that's a yes?
If they want to pay for it. Yes.
Mr. Book?
I think if employers want to offer that, it should be perfectly legal. But
Dr. Blumberg?
I agree, it should stay.
Dr. Haislmaier?
Irrelevant.
Is that a...
It's irrelevant under either the ACA or the replacement because they'll be treated as their own household anyway.
Let me ask about seniors on Medicare, a critical part of the Affordable Care Act. Do you believe that seniors on Medicare should be able to afford their medications and not fall into a prescription drug gap? Ms. Turner?
Yes, and
Dr.
there are
Book?
creative ways to do that.
Dr. Book?
could you repeat the question?
Do you believe that seniors on Medicare should be able to afford their medications?
I think everybody should be able to afford everything.
Great, thank you, Dr. Blumberg.
I agree.
Dr. Haislmaier?
Yeah, I mean,
Yes or no,
comprehensive
Dr.
coverage on drugs
Haislmaier?
is fine. I mean, that's.
Thank you. How about making sure that insurance companies cannot deny coverage because of a person's medical history? Ms. Turner?
That was the case before, and will continue to be the case.
So that's a
going forward.
yes. Dr. Book?
That was the case since 1996, and
Dr.
the ACA
Blumberg?
shouldn't have repealed
Yes,
it.
I agree, but that has not been the case universally
Thank you.
by a
Can
long
you say
shot.
more about that, Dr. Blumberg?
I'm
Yes,
sorry, the
the
gentlelady's time
Thank
has
you.
expired.
I yield back.
I apologize, but we have so many other members, so I hate to cut you off. It's great conversation, and thank you very much. Now, the gentleman from Arkansas, Mr. Westerman, is recognized for 5 minutes.
Thank you, Madam Chair, and thank you to the panel for being here today. You know, it was mentioned that a lot of people want to keep the Affordable Care Act in place. They're fearful that it might go away, but I'll remind the committee that millions of Americans were fearful that they might lose their doctor or their premiums would go up, but they were promised they could keep their doctor. They were told their premiums would go down by $2,500, but from the testimony here today, we've heard that there's been increased premium costs, there's been increased taxpayer costs. People indeed are seeing higher deductibles, they're seeing fewer benefits, they're seeing reduced access. There's been talk about Medicare and what might happen to Medicare, but I'd also remind the committee that when the ACA was passed, that there were cuts to Medicare reimbursements in the Affordable Care Act to pay for Medicaid expansion and the exchange policies, as much as over $700 billion in those cuts to Medicare. I was visiting with a neurosurgeon from my state who has been affected by the cuts to Medicare. He explained it like this: certain surgery might take five steps to the surgery, and Medicare pays for 2 of them. And he assured me that if there's anything he knows about the Affordable Care Act, was that whoever wrote it knew absolutely nothing about medical care. We've heard about the number of people who have benefited from the Affordable Care Act. There's really no consensus on that number from the panel. I believe there is consensus that most of the people who have benefited from the Affordable Care Act are in the Medicaid population. I know that was definitely true in my state. There's arguments about how many people could have already received Medicaid who qualified for it, the woodwork effect, that actually signed up for Medicaid because of the expansion. And you know, if we just take Dr. Blumberg's number of 20 million people who benefited from the Affordable Care Act, if we look at the population of our country, that's 6.2% of our country. So we could say 6.2% possibly got more because of the Affordable Care Act. But I think we fail to remember that 93.8% of Americans are getting less for more because of the Affordable Care Act. As a state legislator in Arkansas, I lived through the debate on Medicaid expansion, and our state did expand Medicaid. It was supposedly an innovative plan that didn't expand traditional Medicaid, but used Medicaid dollars that come from an apparently bottomless pit of money in D.C. to buy private health insurance. So the 324,000 Arkansans that are now on Medicaid that weren't before have a very nice health insurance plan. They've got a Blue Cross plan that they pay nothing for. They don't have a deductible, and it pays the providers very well, but it comes at a tremendous cost. And now over a third of my state is receiving benefits through the Medicaid program. So, Mr. Haislmaier, I want to ask you a question on the Medicaid part. Was the traditional Medicaid system for the aged, the blind, and the disabled, was it having any problems before the Affordable Care Act?
Well, it depends on the state, but yes, I mean, there were clearly problems in the program.
Yeah, I know from my experience there were huge problems in the Medicaid program. And the follow-up to that is, did the ACA do anything to address the underlying problems with Medicaid, or did it simply add a new layer of...
It was mainly an expansion.
Yeah.
It expanded to a new population. They did make some other changes to the program, but they were largely around the areas of eligibility.
So the 324,000 in my state, take away about 7% of that for the woodwork, we're all able-bodied, working-age adults that aren't even part of the traditional Medicaid system, the aged, blind, the disabled. Do you believe the traditional Medicaid population across the country has suffered any damage because of the expansion for the able-bodied adults?
The problem with it is not just so much the expansion. That increases the caseload. But the problem is that there is a sort of inequity in basically the federal government paying the states more for people who need the program less, and paying them less for people who need the program more. I mean, my classic example of this was...
do you think states need more flexibility to design their own Medicaid plans?
Well, in general, but I think also in particular with this population. I mean, one of the things we've learned both in terms of the Medicaid expansion and the subsidies for the very low income in the ACA is that these are people who will show up when they need medical care, but they're not going to stick with it afterwards, and you have to really direct them away from the emergency room, and Medicaid is not set up to do that.
The gentlelady from Florida, Ms. Washington Schultz, is recognized for 5 minutes.
Thank you, Madam Chair, and congratulations to you as well as to our ranking member. The chair noted that I served on the Budget Committee in the 112th Congress, but it appears that I have returned to the Alternate Facts Committee, because that's what we've been subjected to throughout this hearing. Madam Chair, I respectfully want to share with you, in case you aren't aware, that I know you referenced 28,000 people in Tennessee supposedly losing coverage from TennCare, which existed before the Affordable Care Act, but I wonder if it would surprise you to learn that 28% more Tennesseans gained coverage under the Affordable Care Act. That's 266,000 people in Tennessee who now have coverage, which is a far sight better than the 28,000 you referenced who supposedly lost it. I'm also confident if you checked, you would probably see that most of those 28,000, if not all of them, were able to gain more affordable coverage under the Affordable Care Act. In my state, 1.3 million Floridians gained coverage who didn't have it before, the most in the country. And I'll note something that we haven't really talked about here. Let's focus for a moment on the fact that people with employer-based insurance would be gravely harmed from the significant benefits that they gained under the Affordable Care Act. The return of annual and lifetime coverage gaps, coverage limits, preventative care without a copay or a deductible like mammograms, colonoscopies, well woman care, all of which made health care more affordable. By the way, the availability of birth control for free without a copay or deductible has contributed to a precipitous drop in the unwanted pregnancy rate. So the majority of people who already had coverage before the Affordable Care Act will be significantly harmed by repeal. I want to note also that Dr. Book clearly referenced in one of his responses that he supports returning to health underwriting, which was extremely dangerous and harmful and expensive and contributed to death spirals when we had a purely private market-based system. Ms. Turner is clearly advocating returning to strict private market practices that were unaffordable and harmed millions of people. So let's be very clear here. There has not been a replacement plan proposed, and respectfully, my colleagues on the other side of the aisle had 7 years to do that and still have not done it. We have millions of people who gained access to health care that didn't have it before, millions of people who had health care coverage and got better coverage, millions of seniors who can have more affordable prescription drugs, and frankly, also have benefits like being able to go get a checkup every year without a copay or a deductible. Representing a state that has the largest percentage of seniors in the entire country, I can tell you that most of those folks were only able to go to the doctor when they were sick because they couldn't afford copays and deductibles on a well-care visit for them. So we're keeping them healthier as a result. In my last under 2 minutes, I want to ask Mr. Haislmaier, do you believe that, and I would like, in the interest of time, just a yes or no answer, do you believe that all Americans should have access to quality, affordable health care? All? Yes or no? Given the time constraints, again, please answer with a yes or no, and can we agree that health care is a right and not a privilege?
That's the wrong question.
Yes or no?
Because
No, you don't get
no,
to,
no,
you
no,
don't get to dictate
no,
the
I'm not
question,
going to
sir.
answer yes or no on that because
Clearly because you probably don't think it is.
Because
and
all
before the
healthcare is,
ACA, if you won't answer my question, I don't.
facelifts aren't right.
I get to add, my name's on the door, so I get to ask the questions and decide which ones are right.
Okay, but you don't
clearly don't believe that the health care is a right, not a privilege. None of the majority witnesses do. And before the ACA, there was no all-out ban prohibiting discrimination against individuals with pre-existing conditions until age 26, correct?
No, that's not true.
No, it is true. There's no question that an insurance company could drop people or deny them coverage.
No, that's not true.
before
Congresswoman, if you actually read the 1996 HIPAA law, you would understand that that's not true.
That would be news to the thousands of people that I know in my district were dropped or denied coverage. As a breast cancer survivor, I can tell you that I have spoken with many of my sister survivors who were dropped in the middle of their treatment by their insurance company and had to choose.
And that was illegal and they had recourse.
No, it wasn't illegal. It happened every day. And they had to choose between either the chemo or the radiation because they couldn't afford the copays or deductibles on both. That is the nightmare.
The
that
ACA
the
doesn't
majority
require
is.
coverage for
Excuse me,
either.
I haven't asked you a question, Dr. Book. Madam Chair, if you could return a few seconds of my time because I keep getting interrupted, I'd appreciate it. Thank you so much. At the end of the day, the majority is clearly proposing to repeal the Affordable Care Act without assuring us that we would have universal access to quality, affordable coverage. That is unconscionable, unacceptable, and we will not allow you to do it without a fight.
The
I yield
lady's
back.
time has expired. I do want to recommend to my colleagues that keep saying there are not plans out there. There's Orion, Price, Sessions, Rowe, and then there's the Better Way with guiding principles. With that, the gentleman from Ohio, Mr. Johnson, is recognized for 5 minutes.
Thank you, Madam Chairman. I appreciate the opportunity, and I appreciate our panel being here with us today. You know, we're holding this hearing today for one simple reason. Obamacare has failed, and it's caused a series of very serious problems for the American people. I think we all remember the Democrat minority leader famously stating, we have to pass Obamacare to find out what's in it. Well, we've done that, or they did that, and it's full of broken promises that are harming American individuals, families, and businesses. Instead of reducing health care costs, Obamacare has driven up premiums and deductibles, and millions of Americans have lost affordable, quality health care plans and their choice of doctors in many cases. The average annual family premium in the employer-sponsored market has soared, totaling more than $18,000 annually, while deductibles for individual plans are up an average of 60% since 2010. At its core, the law did nothing to drive down the health care costs for the American people. During a time of economic recession and hardship, Obamacare's employer mandate makes full-time workers more costly to hire, resulting in many cases in job reductions, lower wages, and reduced benefits. And these are just a few of Obamacare's harmful effects that we're exploring here during this hearing. And I've listened to some of the questions and comments by some of my colleagues on the other side of the aisle, and I want to agree with one of the things that they say. It's not about statistics, it's about people. But yet they cite statistics about coverage without acknowledging the fact that coverage does not necessarily mean affordable. Because I can tell you in Appalachia, Ohio, along the Ohio River, there are thousands of people who, because of the high premiums and the high deductibles, they don't bother going to the doctor. Even though they might have coverage in the theoretical sense or the technical sense, it's not affordable and it doesn't give them quality health care. So, Ms. Turner, under Obamacare, out-of-pocket costs, as I just mentioned, for families and individuals, including the deductibles, are simply unaffordable and it constrains their budgets. So why, in your view, are costs so high?
They're high primarily because the federal government decided it knew better than the American families do what needs to be covered in their health insurance policies. In addition, the Affordable Care Act included $1 trillion in new and higher taxes, many of which get built into the premiums, as well as rules and regulations that have discouraged the young people from entering. So we therefore have many more young, older, sick people in the pools, not offset by the younger people who would otherwise be there to help lower premiums.
So basically, you've got bureaucrats running our healthcare system instead of physicians and patients.
Correct.
Dr. Book, what are the areas of spending in Obamacare with the greatest unforeseen cost overruns? Do you have some examples you can share with us quickly?
I'd say the the most unexpected thing from the standpoint of the proponents was the huge increases in deductibles, and that was the result of a system that encourages sick people to sign up but discourages healthy people to sign up, especially if you're under 26. You know, why buy an exchange plan when you can get on your parents' plan? And then regulators try to crack down on premiums, and they can't cut covered services because there's a whole bunch of required covered services, so the only thing they have to do is increase deductibles. And what used to be a high deductible plan that qualified you for a tax break, if it was $2,400, is now lower than any deductible you can find. Now people are paying $9,000 for a deductible, which, by the way, is double the statutory limit, because the previous administration issued a waiver allowing deductibles at double the level the text of the ACA actually allows.
So just one quick final question, because I'm out of time. So has Obamacare successfully bent down the cost curve in healthcare spending?
No. In fact, in the last year that data is available, the cost went up 5% per capita. The 5-year average before was 2.9%.
Okay. Thank you, Madam Chair. I'll yield back.
Your time has expired. The gentleman from California, Mr. Carbajal, is 5 minutes.
Thank you, Chairwoman Black, and thank you, Ranking Member Yarmouth, and all my colleagues. I'd like to thank all the witnesses that are here today. And I want to start by saying that, you know, the Affordable Care Act never purported to be perfect. So it's important to recognize that as the baseline by which we are debating and discussing this. It did a lot of good. It continues to have some challenges, but it did a lot of good in attempting to fix a broken healthcare system that we all know we had and continue to have. We need to build on that. It's been 3 weeks since I was sworn in as a member of Congress. In this short time, I've seen the Republican majority take concrete action to begin dismantling the Affordable Care Act. And I am deeply concerned about where we are headed. We have heard no substantive plans from the Republican majority to replace the ACA with a proposal that would match the benefits provided by the ACA. I would love any plans that have been proposed to become available so that I could see them firsthand. Now, I want to be clear. I do not believe the Affordable Care Act is perfect. There are changes that can be made to make it work better. I've heard from constituents who have greatly benefited from the healthcare law, and that is the reason I am here. I asked my constituents to share with me their stories about how a repeal would impact their lives. And I'd like to share some of those stories with you, not statistics, but some of those stories. Sherry, a small business owner in Los Osos, in my district, lived without health insurance for years until the Affordable Care Act, hoping that their young son wouldn't get sick or break a bone. Brian in Santa Barbara was uninsured for nearly 20 years because he couldn't afford health care coverage. The Medicaid expansion under the ACA allowed him to get covered. Just last year, Brian was diagnosed with a degenerative disc disease, and without surgery covered by this medical expansion, he would have been left severely disabled. He told me the ACA quite literally saved his life. Eldana in Avila Beach donated her kidney the same year the Affordable Care Act was signed into law in 2010. If not for the Affordable Care Act, her life-saving act would have prevented her from obtaining health insurance due to a new pre-existing health condition as a living donor. These are just a few of the stories that I have heard about tangible life-saving impacts the Affordable Care Act has had. I see I'm running out of time. Dr. Blumberg, can you elaborate more on how repealing the Affordable Care Act would impact my home state, California?
Well, I don't have my California-specific numbers in front of me, Congressman, but as the largest
Let me ask you a second question then. What do the people losing coverage look like to you? Are they working families? Are they mostly poor or not?
So about over 80% of those who would lose coverage are in working families, and the vast majority of those have at least one full-time worker in the household. 53% have incomes between 100% and 400% of the federal poverty level. That's about $24,300 for a family of four is poverty. It's spread very broadly across the age distribution, contrary to some of the things we've heard. There's been the biggest uptake in coverage has been among young adults, and 80% are people who have not obtained a college degree.
Thank you. I come from a working family. My dad was a farm worker. I've seen people back home struggle to pay their medical bills when a family member gets sick. It's imperative that we continue to work together, providing affordable health care coverage for all, especially these working families that stand to lose the most from repeal. I yield back.
The gentleman yields back. The gentleman from Minnesota, Mr. Lewis, is recognized for 5 minutes.
Thank you, Madam Chair. For the record, anyone on the panel can answer this. The HIPAA law of 1996 does not allow or does cover by law pre-existing conditions employer to employer. Is that correct?
Yes.
Yes.
That is correct.
Oh, I just wanted to get that in for the record then. I do want to talk a little bit about what the ACA has done in Minnesota. Now, there's a lot of talk from the other side about how repeal would impact certain groups, but we know what the law has already done. In my home state of Minnesota, which is really at the epicenter of all this with MNsure, the Commerce Commissioner there called it an emergency situation. 2 years of back-to-back premium increases, 50% and 67%, 100,000 people being shoved into a default option. The governor, Governor Mark Dayton, whom we're all wishing well today, called the Affordable Care Act is, quote, no longer affordable. It is an existential crisis in the state of Minnesota. So we can talk all day long about what repeal and replace is going to look like, but we know what the current law looks like. And it has been a disaster. 1,000 counties in the United States have one insurer to choose from. Now I want to focus a little bit about on two things. One, employer coverage, as well as what we call the age rating or community rating in some circles. First of all, I believe Grace Marie Turner has commented on the Affordable Care Act not just hitting the individual market. What we're hearing from the other side is, well, gosh, you're just talking about 5% of the people in the individual market being hurt by all of this. It's no big deal. 95% of the people have coverage in their very healthy employer pool. But in fact, the Affordable Care Act has really impacted employer coverage too, has it not?
Absolutely. And as we heard earlier, the requirements of the law have significantly driven up costs and deductibles to the cost of the average family policy for employers is now $18,000 a year, more than $4,000 higher than it was before, not the $2,500 savings that they were promised.
And Mr. Book, to your point, an acquaintance of mine recently was offered a plan at work, again, not the individual market, employer-based coverage. His deductible was $13,000. The family plan was well over $1,500 a month. This is living proof that health insurance is no longer health care.
Right. Well, yes, and that's how kind of deductible was unheard of before the ACA. Nobody had a $13,000 deductible before that.
It used to be in the market-based economy, it would work a little bit like the bond, 10-year bond. Right. You know, the interest rates go up, the bond goes down. Right. Premiums go up, your co-pays, deductibles go down. Right. Now we're getting massive hikes in premiums, along with massive hikes in co-pays, stricter drug formularies.
Correct.
All sorts of things that were unheard of just a few years ago.
That's absolutely right.
Anybody else want to comment on that?
I would like to comment. There was some turmoil in the early years of the ACA in Minnesota because of problems with underpricing by the co-op and then the removal of the risk corridor payments that were intended to pay, and that was a congressional decision, and that really financially harmed the market in Minnesota tremendously, and I get that. But 380,000 people have gained insurance coverage through, or are at risk of losing their health insurance coverage through repeal in Minnesota alone.
I can tell you the insurance companies are more than making up for that underpricing early on.
No, and I understand that.
67%.
And there are some strategies that we can discuss for stabilizing the market there and increasing competition within the framework of the Affordable Care Act.
I think there's just going to be soon one insurer left in MNsure, the state exchange. They're fleeing the state.
But if you want to discuss it, I can give you some ideas of how you might increase competition.
I want to get one more question in for Mr. Haislmaier, and that is, do you know of any economic model where freely floating prices are not a requirement for the proper allocation of assets?
No.
All right, so why are we putting price controls on the health insurance market that basically says, well, gosh, the price has to be within a band for everybody, which is effectively jacked up premiums so high that we've priced young people out of the healthcare market.
Well, basically, that's a pricing convention, and what you can do is you can sort of categorize them in bands. The problem there is, yes, you've compressed the bands to the point where you've increased the cost for young adults significantly more than you have, reduced them for older people and priced them out of the market. Yeah, it was one of the things that really, even from the perspective of a supporter of this law, didn't make a lot of sense to start with, because those are people who are most likely to be price sensitive and uninsured.
I think Milton Friedman warned us about price controls at one point, right? Causing surpluses and shortages. Yeah. All right, thank you, Madam Chair. I yield back my time.
Gentleman yields. Mr. Boyle, you're recognized for 5 minutes.
Well, thank you, and thank you for recognizing me, and very much appreciate being on this committee. Regret that this morning the service on my other committee has a hearing meeting at exactly the same time, so trying to run back and forth to the two. I will have questions for Dr. Blumberg, but I first just want to reiterate something that I said on the House floor last week and go into a little bit more detail since I have more than a minute. It is interesting that about 16 years ago, I was sitting in a graduate school class at Harvard's Kennedy School, and there was a fellow from the Heritage Foundation, Stuart Butler, saying that he had an idea that was an alternative to what was then characterized as quote-unquote Hillary Care. Before it was demonized as Obamacare, it was first demonized as Hillary Care. And the alternative to a government-run, single-payer system, essentially Medicare for all, was to pool the uninsured together through a series of taxes and tax credits, combined with a mandate to purchase insurance and banning discrimination against those with pre-existing conditions. Pool these people together, and instead of having a government-provided single payer, we would instead pull them together and enable them to purchase private health insurance plans. In fact, that was the genesis of the bill that was introduced by then Republican Senate leader Bob Dole and 17 Republican senators in the mid-1990s. Fast forward 2 decades, we know it and the root of it as Obamacare, and suddenly it's an idea that's akin to socialism. So if the other side really wants to repeal and replace what was the market solution to the Democratic plan of the 1990s, and wants to instead repeal it and maybe replace it with a single-payer system or some sort of Medicare for all, I would be someone on this side of the aisle that would be interested in that sort of repeal and replace conversation. Now, let me address some of the rhetoric that we've heard recently in the media, because I'm confused about it. We keep hearing that Obamacare is in a quote-unquote death spiral, and that it will quote-unquote collapse under its own weight. But then I actually look at the facts, and I see 22 million people who are insured. I see that in 2010, the percentage of Americans uninsured was approximately 16%. Today, it is 1/2 of that, 8%, the lowest percentage in American history. So Dr. Blumberg, could you rectify these clear discrepancies between the rhetoric of a death spiral and the actual facts?
Sure. The Affordable Care Act markets are not in a death spiral. Coverage is increasing in them, and there are a substantial percentage of the population lives in areas where there's been either modest increases in prices or actually decreases in the lowest cost silver options that are available there. So there are some markets that have had big percentage increases because they were correcting for earlier underpricing, and then there is a set of states that are having issues related to lack of competition in either their insurer or provider markets and adverse selection, and those are the markets that we should be addressing with policy, but we shouldn't be presuming that this is one big market that's collapsing. That's absolutely not true.
Yeah, and I think a couple of those states are Minnesota, like we heard, Arizona, I think is another word. They have their own unique challenges that are not necessarily representative of the nation as a whole.
That's correct.
Yeah. I did want to, since I cited the figure of 22 million people that are now enrolled through the exchanges, But in fact, if we were to repeal the Affordable Care Act, the number of people that would lose their health insurance is upwards of 30 million. Isn't that correct? And could you expand upon that?
Our estimate is that 29.8 million would lose their coverage in 2019, and that would be a consequence of repealing all of the financial assistance and the individual mandate that bring in the healthy population into the pool while leaving in place the consumer protections that prohibit discrimination against the sick. Those two things going together end up not just eliminating the coverage for people who gained it under the law, but collapse the market for people that were buying with their own funds.
Okay, and of course, finally, since I'm down to 10 seconds, the 29.8 million figure doesn't even include the number of seniors in my district that have gotten benefits such as lower prescription drug costs because of other changes that came in with the Affordable Care Act.
Right, because they wouldn't become
Gentlemen's
uninsured.
time's expired. We'll now hear from Mr. Bergman for 5 minutes.
First, thank you, Madam Chairman, for giving me the opportunity as a member of the new committee, Budget Committee, to be here and ask questions today. As a new member, I came to Congress with a promise to my constituents of Michigan's 1st District to serve them and to make sure that we are being responsible stewards of their hard-earned tax dollars. So it's only fitting that we're here today to discuss the harmful effects of Obamacare. This law has raised taxes on families and small businesses, discouraged economic growth and job creation, and has ultimately placed the government in the driver's seat for personal health care decisions. I'm looking forward to working with my colleagues across the aisle, here in this committee, and in Congress in general, on meaningful, real reform to our health care system. My first question for Ms. Turner: the authors of Obamacare tried to set up tools to help small businesses get access to health coverage, such as a small business tax credit, a special insurance exchange known as the SHOP exchange. Are small businesses better off or worse off because of Obamacare?
The polls that are taken by the National Federation of Independent Business and other organizations say absolutely not, because their costs are still so high, and they were very disappointed at the effect of the promise that they would have tax credits and relief, which they have not seen, and felt they had to jump through way too many bureaucratic hoops, and the tax credits were far too restricted to be of use to them.
Again, Ms. Turner, what are the lessons that we should take from our last 6 years of Obamacare to truly provide access of affordable health care for the small businesses? And my district has a tremendous number of small businesses. What are the lessons?
The lessons are to listen to them, that they want to provide health insurance for their members. They cannot do it if the policies that they're required to offer are so extraordinarily full of benefits that the prices are prohibited. It hurts everyone to try to promise them everything, and they can't afford it.
Thank you. Dr. Book.
Yes.
As we prepare to legislate in this area to provide patient-centered health care reforms, what are the biggest lessons from the Obamacare experience that we should heed? Conversely, are there positive aspects of the health care law that have performed better than anticipated that we should be aware of? So, pros and cons.
All right, so I think the most important lesson is patients have a better idea of what type of coverage they want than, people who are sitting here in Washington telling them what to want. People should have the right, if they wish, to buy a comprehensive health care plan that covers everything imaginable. If they wish to choose a more basic plan, that should be an option. If they wish to choose a more, a catastrophic plan, which is, with a $9,000 deductible, that should be an option as well. What they shouldn't have to do is buy a comprehensive plan with a catastrophic deductible, which is which is basically the only option that people in the individual market have right now. I think the goal of allowing people to buy insurance without even if they have pre-existing conditions, is an admirable goal. It's an important goal. It's an essential goal. However, the ACA went about this in a completely wrong way that left millions of people unable to afford coverage. It also left insurance companies not covering a lot of conditions. You know, in the first year of the ACA, there were actually fully compliant ACA health plans that did not cover cancer treatment at all, because that was not one of the essential services required by law. I guess someone just forgot to list that.
Thank you.
Sorry.
Thank you. I want to get to, because I've got about 30 seconds left. Mr. Haislmaier, can you explain the difference between subsidized and unsubsidized coverage and what that means for individuals who are purchasing coverage?
Well, the Affordable Care Act has a set of very generous subsidies for people who meet income and other criteria and purchase through the exchange. So when I'm talking about the market, those are the people I'm referring to who are receiving subsidies as subsidized enrollees. You could also refer to people who are on a public program as a subsidized enrollee. The others
Gentleman's
who are
time's
buying in the
expired.
same market.
We'll now hear the
Thank
gentleman
you.
from Massachusetts, Mr. Moulton, for 5 minutes.
Mr. Chairman, thank you. You know, there's been a lot of discussion here back and forth about conflicting ideas, perhaps alternative facts. But I just want to get down to some facts we can all agree on. Some simple things about the situation we find ourselves in now here in Congress. The first is that Republicans have tried to repeal the ACA 65 times. 65 times they have voted to repeal the ACA without a replacement. Not on the first try, not on the 4th try, not on the 12th try, not on the 65th try. I heard our Madam Chairman discuss at length her anecdotal evidence for places where Obamacare has come up short. Not once did I hear her propose an alternative. If we want to fix this, then let's propose a plan. And hope is not a plan. Ideas are not a plan. Second, we get lectured in this committee a lot by the other side of the aisle about fiscal discipline, about how if American families and small businesses can balance their checkbook, then Congress ought to be able to too. And you know what? I agree with that. I strongly agree with that. And yet here we are, where repealing the ACA without a replacement, as the Republicans have already begun to do, would cost roughly $350 billion through 2027. In fact, it will be so bad for the deficit that Republicans had to repeal the rule that bans reconciliation from being used to increase deficits. They had to repeal that rule so that they can increase the deficit dramatically by repealing Obamacare. It's going to break our bank. The gentleman from California said, isn't it shocking that we have $1 trillion spent on health care, and yet there are some people who are left out? What's shocking to me is that you want to spend even more than that, and yet leave 30 million people without health care. Now, the third thing that we can all agree on is that the Congressional Budget Office estimates that repealing the major coverage provisions of the Affordable Care Act will terminate coverage for, sorry, not 30, but 32 million people. Just like to put that number in perspective. No, sorry, not the slide of the people who didn't show up for the inauguration. Can you see the next slide? Yes, the Women's March, right. This Saturday, roughly 3 million Americans gathered in cities all over the country for the Women's March, the largest single-day protest in American history. If you multiply that number by 10, that is how many Americans would lose their access to the affordable, quality care they receive in the ACA. We're just looking at Washington here. 3 million Americans all over the country. Multiply that by 10. That's how many people we're talking about losing their care. I'm a veteran myself. I am particularly proud of the fact that between 2013 and 2015, the uninsurance rate for non-elderly veterans fell by an estimated 42%. 42%. And we're going to put a lot of those vets out in the street without health care if we follow through on this. Two leading doctors at Harvard Medical School have concluded that 43,000 people will be killed annually if the ACA is repealed without a replacement. And not just a replacement, but a comparable replacement. A comparable replacement. Madam Chairman lectured us on how we should not govern, or how we should govern by anecdote, because she cited some people who are not happy with their current care. Those 43,000 people aren't just anecdotes. They're people too, who will lose their care if this is repealed. For your congressional districts, that's about 1 in 17. 1 in 17 people in your congressional districts, that's what that means, who will die if this is gone. Thank you, Mr. Chair. I yield back.
Gentleman yields back. Remind the gentleman that in 15, when the Obamacare repeal got to the president's desk, had he signed it, the deficit could have nearly been erased because CBO scored that as a $500 billion savings. Gentleman from New York, Mr. Fazal, is recognized for 5 minutes.
Thank you, Mr. Chairman. A number of the witnesses have discussed the age banding, and we know that there are approximately 8 million people that have chosen to not buy coverage, either because they can't afford it, they don't know enough about it, or they've just simply decided it's a better deal for them to pay the penalty. I'm wondering if, I know Ms. Turner and Dr. Blumberg have both referenced in their testimony the 3-to-1 ratio, which is in statute as I understand it. What should, if the panel could each offer us, what should that ratio be if we are to amend that portion of the law?
This would be a decision best left up to the states, but a 5-to-1 age band was previously considered a pretty good standard, but it's something that is very difficult for the federal government to make one standard.
From my perspective, you shouldn't change the 3-to-1 age band to something broader unless we provide more financial protection for older adults, because the point of putting those tighter age bands in was to make it so coverage was not excessively unaffordable for older adults paying for their full premium. So if you can put in more consumer protections, financial protections, for example, everyone over 400% of poverty pays only no more than 8.5% of their income for a standard policy. Then you can loosen to 5-to-1, because what you're doing is you're redistributing these very high costs that we accrue as we get older by income instead of by age. But for now, I wouldn't move that.
Thank you.
But the effect has been to discourage young people getting in, and actually it harms older people now currently, because the younger people simply don't enroll because of this 3-to-1 band.
It doesn't harm older people, and I think you've far overstated the circumstances. It's my turn now. You've far overstated the circumstances, because age is very inversely correlated with income. So actually, a very large percentage of our young adults are eligible for financial assistance, which caps what they have to pay relative to their income when they enroll through the marketplaces, and that protects them. Our analysis has found is that there is no difference in coverage as a consequence of 3-to-1 versus 5-to-1. It's a matter of who's going to be uninsured, a little more uninsured, older adults who need a lot more care, or younger adults who need less.
Thank you, Dr. Blumberg. Dr. Book, did you have something to add to that?
Yeah, thank you. To answer your first question, I'd recommend not specifying that in that ratio in the statute. Prior to the ACA, some states did not have that in their own state statutes either, and the ratio is usually 5-to-1. We find with the ACA, premiums even for older Americans have increased relative to what they were before. So I don't think this 3-to-1 is necessarily saving them money, because they're paying more.
Okay, Mr. Haislmaier, do you have something to add to that?
Congressman, I can supply you with a study that was done by the American Academy of Actuaries that has looked at the relationship between age and healthcare expenditures. And basically, when you look at that, if you assume that there is a blended rate, meaning that you're not differentiating between men and women, because women tend to be more expensive younger, and then that flips and men are more expensive when they're older. But if you assume a blended rate, then the approximately 5 to 6 to 1 range is the natural variation in healthcare spending, and
Thank
that
you.
would be.
One last question that the panel, if you could briefly answer, since I have 1 minute and 19 seconds. The essential benefits, my understanding that is done through strictly regulation now at HHS. What changes would you recommend in that regard, Ms. Turner?
There are 10 specified categories in the ACA. The HHS Secretary has broad license to redefine those, and I think that is something that the American people would like to have looked at again so that they can have more flexibility.
Dr. Book?
Yeah, I'd like to say a word about preventive care, which is listed as a general category, but somehow, in reality, preventive care does not include anything that actually prevents you from getting sick. For example, high blood pressure medicine is not included, cholesterol medicine is not included, blood thinners for people who have had strokes is not included. It just includes things like vaccines, screening tests, and contraception. So a lot of the things that actually prevent people from getting sick and prevent people from needing more expensive treatments are actually not counted as preventive care according to the ACA and its regulations.
Dr. Blumberg?
One must remember before you remove something from an essential health benefit or remove all essential health benefit requirements is that as soon as you take something out of that benefit package, it is out of the sharing of healthcare risk across the population. And any individual who needs that particular type of care is going to have to pay for it completely out of their own funds. And this will make that unaffordable care in many circumstances for many individuals.
The gentleman's time's
Thank you, Mr.
expired.
Chairman.
The gentlelady from New Mexico, Ms. Lujan Grisham, is recognized for 5 minutes.
Thank you, Mr. Chair. And while I hadn't intended to have this be the focus of my question, and I hope I don't lose all my time as a result, what's really hard about these hearings is that both sides have a limited amount of time to shoot out their soundbite. And these falsisms or truisms don't get us anywhere closer to dealing with real healthcare reform. And for somebody who's worked in healthcare for more than 30 years, I remember HMOs and I remember Medicare Part D and the problems with formularies. And I can tell you that insurance companies and pharmaceutical companies are not trying to make it affordable for anyone. And I know that we've had lots of debates that have been bipartisan in Congress about hospital costs. And I just am really struck by the conversation about what HIPAA does and doesn't do. And most people in Congress, I'll bet, have no idea that it's a privacy portability law that made some changes to the prior COBRA protections, which basically means when you lose your job or change your job, there ought to be some way to take that insurance protection with you. But what we don't talk about is it was the full cost, and it's time limited out. And if you don't get into another group plan after 24 months and you don't know to appeal and you don't have a lawyer or you don't have me, then you don't get an extension. And if you had cancer, you're in real trouble, which is why we have so many bankruptcies and why people are so frustrated because while somebody on my side of the aisle didn't quite get that right, her point was it doesn't really work in the way that we thought it did. And most high-risk pools around the country did not provide subsidies, which meant you were still paying the full cost of your care when you were excluded by pre-existing condition, which is why so many Americans are so frustrated, and we in Congress aren't dealing with the real perpetrators of cost. You want to talk to doctors, which I do nearly every month, bipartisan, all different practices and relationships. They don't want to work for insurance companies. Not worried about bureaucrats nearly as much as they are worried about corporations that tell them what they can and cannot do. You want a patient-centered system? Take out the people that I have no control over. I have access to my doc, but I can't deal with my insurance company or pharmaceutical company that won't put any of the drugs, Dr. Book, that you just mentioned, as preventative care. It's not the ACA. We don't allow any negotiations with any of those pharmaceutical companies. And until we start to do real work in that regard, then the issues that you have by both members of this committee, including the mother pregnant with twins, husband lose a job, without the ACA, no way, and they're born prematurely, can she deal with it with the ACA, another one of my constituents, because insurance companies and hospitals do all sorts of interesting things, including in hard-to-serve places like my state, but certainly not just like New Mexico, but all across the country, we do interesting things like this. So this hospital is in my network. And this hospital does women's care, which means they do maternity care, which means they gotta have a neonatal wing. But guess what? That hospital is gonna contract out with a Florida company. It's gonna provide those neonatal services. Now, I don't have any access to that information. I choose a plan, I go to the hospital in my plan, I give birth to triplets prematurely. Those triplets are very sick. One survives. No complaints about the quality of care by this neonatal team. Now you need specialty care for the twin that survives, that's severely disabled. And guess what I got? I got a $30,000 bill just for the first couple of weeks in neonatal care. You know why? Because they weren't part of that network. And the ACA didn't prevent that. The ACA didn't cause that. Insurance companies caused that. Now, I was able as a member of Congress to solve that problem. I have legislation, ladies and gentlemen, that would prohibit that. I don't think it's ever gotten hearing. Anybody who wants to get on that bill, call me after. There are plenty of problems with large corporations and hospitals who have created huge cost problems and practices in this country. One of the real issues, not the only one, we don't embrace public health in this country. Every other country that deals with reasonable health care costs, and you want to get to prevention, then let's do public health. So my questions were, are there any proposals to Linda Blumberg that you've seen in Congress? I won't even pick on Republicans, because I know about the health savings account, and I know about privatizing Medicare, that would actually reduce deductibles or out-of-pocket costs, which I would agree, I'd love to see those go down. Any?
No.
Me either. Not for 30 years.
Gentlewoman's time has expired. We'll now
I
hear
yield
from the
back.
gentleman from Pennsylvania. Thank you, Mr. Smucker, for 5 minutes.
Thank you, Mr. Chair. I'd like to thank the panelists for being here today. You know, I think it's important we not lose sight of the goal that I think is shared by everyone up here today, both sides of the aisle, and that is we want to ensure that individuals, Americans, have access to quality health care at a price they can afford. And I'm looking forward to working with my colleagues on both sides of the aisle to design such a system, because we know the ACA has not done that, has not worked. And granted, there are some who have had access to health care for the first time through ACA. And we're not going to pull the rug out from under them. We want to ensure we have a system that gives them better coverage, better care. But what I've been hearing, and I, of course, like so many others, I'm a first-time freshman member, have come through a 12-month campaign, primary and general, and the Obamacare system was been top of the list in people's minds. And what I've heard from constituents in my district is what we've been talking about today. People have seen extraordinary increases. People who had health insurance before have seen extraordinary increases in the cost of their premiums. 25% average increase in premiums across the country. It's higher than that in my area. I've talked to people who have seen doubling of their premiums. And then I've heard of others who have lost their insurance altogether, who have been forced onto a plan that they didn't want. So clearly what we have isn't working. I think there are better solutions, and I'm looking forward to working with the college to achieve that. The other, and my background is a small business owner. I've been a small business owner for 25 years prior to serving in the state senate. And I've spoken to a lot of small business members over the last year as well. And I'll just share one brief story. A husband and wife team who operated a small machine shop in Elizabethtown in the Lancaster County portion of my district. And they pride themselves, they have 10 to 15 employees, I forget the exact number, but have been in business for quite some time, have always prided themselves in creating a kind of family atmosphere among their employees. They see their employees as family, have always provided quality health care, seen that as an important part of their pay and benefit package, and literally believed that they may not be able to do that any longer, and were very, very worried, not only about how it would impact their business and their profitability as a business, but how it would impact their employees and their employees' families. And I think this is one of the impacts of the Affordable Care Act that we have to find better solutions to allow employers to continue to provide that kind of service to their employees that they think is very, very important. But I want to get back, and I've taken up most of my time, but I do have a quick question, and I think Mr. Haislmaier, you had talked about self-insurance. As a business owner myself, we were one of those businesses that were self-insured, and we found it an effective way to control costs, because you created a partnership with your employees and with the company. You designed a system that worked for employees and then created incentives for controlling costs and so on. And just recently I talked to a business owner who said over the last 5 years they haven't had the kind of increases that many others have seen in health insurance, many other businesses have seen. And when I asked why, I said, well, we're self-insured, so we've had a very, very good experience with that. I think you mentioned that we've seen a slight increase in self-insurance after ACA, and I guess I'd be interested in learning more about that and whether you see this as an important part of the solution.
The most notable shift has been a significant drop-off in fully insured employer plans, which is where you go and buy the coverage from an insurer on a group basis, and the insurer retains the risk. Those tend to be smaller and medium-sized businesses. Up until recently, you know, the self-insured market has largely been large employers, but it's moving down the firm size scale. That is by far, just to give you a relative concept, that has grown, but it's been a steady 2% sort of growth every year, but it's already from a high base of about 100, started out at about 100 million people in that. One of the reasons that, and I've been looking for this, I haven't seen a significant acceleration in the data, but
I'm
because
sorry,
of
the
the
gentleman's
ACA,
time's
you
expired.
can get out from under
The gentleman's time's
regulations that
expired.
way.
Mr. Gates of Florida, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Hope is not a plan was the admonishment we received from the gentleman from Massachusetts. It is perhaps also a fitting title for the obituary of the last 8 years. Time and again, we've heard our Democratic colleagues on this committee say there is no replacement, there is no plan that Republicans have offered. And whether they're here with us or back in their offices admiring their names on the wall, I would suggest that they look at the legislation offered by Mr. Rokita, where he has said that if we functionally block grant Medicaid to the states, then we can experience the great vibrance of a federalist system, where best practices will be attempted and copied. And sure, there'll be some who miss the mark, but that's sort of the deal we get in a constitutional republic, and I certainly join Mr. Rokita in attempting to advance those efforts. I want to, for a moment, speak about emergency room visits. There was a promise in Obamacare that we would see a reduction in emergency room visits, but I've noted a 2015 study from Northeastern University suggesting that emergency room visits post-Obamacare in Illinois are up. Another 2015 survey from the American College of Emergency Room Physicians, where 3 in 4 emergency room physicians are experiencing higher emergency room volume, not lower volume, following Obamacare, and a February 2016 study from the Center of Disease Control suggesting that there's really been no reduction in emergency room visits as a consequence of this law. And so I guess my question for Dr. Blumberg is, why has Obamacare failed to reduce the number of emergency room visits?
Well, first of all, I think it's not fair to assume that any change in emergency room visits is inappropriate use. So in some areas, you may have there are always provider shortage areas where people tended to use emergency room care more. those provider shortage areas were prior to the ACA, and they still exist.
Sure,
But in
Dr.
addition,
Blumberg,
when you see an increase under the Affordable Care Act, what you're doing is you're lowering the price of medical care to people. And so people who couldn't afford necessarily to go and get an emergency room care when they needed emergency room care now have financial access to do so. So it's not necessarily just because you see an increase that's an increase in inappropriate use.
Reclaiming my time, I'm glad you mentioned that. So let's then turn to the state of California, the state that has perhaps most enthusiastically embraced the expansion of Medicaid, where currently 1 in every 3 Californians is on their Medicaid product, 13 million people. Across the board, reductions in reimbursements to providers. We read in the Los Angeles Times the story of Kevin Hill, 58 years old. He was one of these Americans who was added to the Medicaid rolls. He had to call 15 doctors in the Long Beach area. Either the doctors weren't even answering their phones, or they weren't taking CalMed patients anymore because reimbursement rates were so low. And where did Mr. Hill end up? Back in the emergency room. So I guess, you know, the question is, if you've got a circumstance where you've got enrollment that is spiking beyond the ability to raise taxes to pay for it, and reductions in what we pay providers, what is the hope looking forward?
Well, I think we shouldn't make our public policies based on anecdote, and I do appreciate the story of your one constituent, but there's a lot of people who are getting Medicaid coverage now who have a usual source of care, and we can demonstrate this through household surveys that never had a usual source of care before, and that's
Dr.
outside
Blumberg,
of the
reclaiming my
emergency
time,
room.
you know, it's sort of like shifting ground when I cite the statistics that indicate that there's rising participation in our emergency rooms. The statistics can't be trusted. When we cite the
No, but I
individuals
said-
who cannot go and obtain care, then we can't trust the anecdotes.
But I did say when you lower the price of medical care, more people have access to use it. But that doesn't mean we aren't also increasing access to usual sources of care for people
then-
who are uninsured for the first time under the Medicaid program, because the evidence is very strong that we are.
Well, then let me conclude my time with some bipartisan agreement with the gentlelady from New Mexico. I agree wholeheartedly with her statements that we have real cost problems and cost drivers, I think frequently aided by a hospital industrial complex and an insurance system that, for the most part, has been supportive of the Affordable Care Act and does not want its repeal. And so the very people that the Democrats on this committee criticize for being the drivers of cost are the very same entities that are bellied up to the trough, draining resources away from those who are truly vulnerable. And so I join the bipartisan sentiment about trying to attack those cost drivers, but it seems as though focusing only on coverage, which is illusory, which doesn't lead to real care, it just leads to more folks in the emergency room, is not the better way that we should all be pursuing.
Thank the gentleman. Gentleman yields back. The gentleman from Texas, Mr. Arrington, is recognized for 5 minutes.
Mr. Chairman, thank you, and I'm honored to represent West Texas. I'm honored to be on this committee, and to the ranking member, Mr. Yarmouth, I look forward to working with you and your our colleagues on the other side of the aisle. The jury isn't out in West Texas on Obamacare. Never, and I've been around public policy and politics a long time, never has there been a greater disparity or irony between the title and intent of legislation and its outcomes for the American people. It's not affordable care. It's the Unaffordable Care Act. It is the Raise $1 Trillion in Tax on Americans Act. It is the Kill More Small Businesses and Jobs Act. It is Crush the American Economy when it's coming up for air from the Recession Act. It's weaken the Medicare Act by taking $800 billion from that program. It is make it more difficult on middle class and working class families. Let me tell you something. In West Texas, we don't care about the names on the halls and walls of Congress. We care about the people that have their names on their shirts and on the back of their belts, and they're getting creamed. How serious is this that we act now, that we act swiftly and with confidence, that this paradigm, that this top-down, government-run, centrally planned, one-size-fits-all health care has failed us? How urgent is it that we act? How serious is it that we act? Ms. Turner.
Absolutely crucial, and a new system cannot be built on the wreckage of Obamacare. You have to repeal it first. That's why members of Congress could not replace legislation because the president vetoed the repeal bill.
Other members of the panel?
It's clear that simply repealing the ACA will not bring back the system that was destroyed by the ACA. That previous system also had a lot of problems with it, and that this is an opportunity to create a more caring and more feasible and more affordable and more economically rational system in which people can actually obtain the care they need instead of just obtain their $9,000 deductible.
See, I'm just a freshman congressman, you know, and I'm trying to make sense of all this and this alternate universe and facts that have been mentioned. And I see the American healthcare system as a patient on the operating table in the emergency room bleeding out. And we're expected to take an ACE bandage and an aspirin and somehow allow it to live to see another day. And the people I represent don't believe that. I'm not disparaging or questioning the intent. The intentions were to provide affordable care. The outcomes were that it didn't, period. And it's only the responsible thing to do for those who lead our country and represent the good people of these United States to step in and do something and provide solutions, real patient-centered solutions, market-oriented solutions, flexibility to states, empowerment of the patient to actually be a consumer of health care and create real markets where health insurance companies are competing for our business, driving the cost down and quality up. Good old-fashioned free enterprise American way. And I come from middle America. I come from rural America. And as I said on the floor the other day, when America's sick, and believe me, the folks in the 29 counties in Texas District 19 would reaffirm this statement. When America's sick, and they're sick from Obamacare, and they're sick of Obamacare, and they're sick of big government being thrust upon them as the solution for every problem that ails us. But when America's sick, rural America is in the ICU. Small businesses, family farms, community banks, rural hospitals. Put the slide back up, please, if you would, of the 80 rural hospitals that have gone away. 600 on the brink of going away. How are we going to bring the food, fuel, and fiber to America if we don't have health care infrastructure? But the $58 billion in additional regulatory cost, we can't do it. So if you want to feed and clothe the American people...
I thank the gentleman's time's expired. I'll now hear from the gentleman from Georgia, Mr. Ferguson, for 5 minutes.
Mr. Chairman, Ranking Member, thank you so much for the opportunity to address the panel. I thank you each for your time, and thank you all for coming. I'm going to start with a question, and I don't mean it to sound facetious. How many of y'all sitting at that panel have delivered health care as a provider to someone in a rural community living below the poverty level? You have, in the last 24 months.
Yeah, I'm a volunteer for Remote Area Medical, so we work in Appalachia delivering care.
Good, okay. So a lot of the conversation that we'll have, we will be able to connect with, okay? As I go through this, one of the things that I want to explore is the regulatory cost that has been added to healthcare delivery. Can y'all explain to me, in the Affordable Care Act, how there's an intentional effort to lower regulatory cost in the delivery of health care? And I'll start with Dr. Book.
Within the ACA?
Yes.
Within the ACA, I don't believe there's any attempt to do any of that.
Okay, thank you. Would you all agree that there is increased regulatory cost as a result of the Affordable Care Act? And Mr. Haislmaier, I'll ask you that question.
Yes, so that's not evenly spread. I mean, in more certainly more in certain sectors than others, but yeah, it's significant increased regulatory cost.
With that increased regulatory cost, and as a provider, this is something that I live with every single day. We are spending more and more time on regulation and less time on the most important part of healthcare delivery, and that is the intimate conversation between a doctor and a patient. As I move forward every day with treatment with my patients, the single most important thing that I have to be able to do is to communicate in an effective way with my patient the value of the health care that's being delivered. And I do that every single day. What I have seen in recent times is that we have less and less time to do that. How in the world, just because you have access to health insurance doesn't mean you have access to care. I'm sure that's been said many, many times around here. It is true. Has the Affordable Care Act looked at the other barriers to access to care besides simply access to insurance? I will tell you, in my practice, I treat patients every single day, from folks that are trying to figure out how to get their next meal to a family with unlimited means. I do it every single day in my dental practice. There are a lot of other barriers to care for those that are caught in a cycle of poverty. Dr. Blumberg, you working in Appalachia can probably see that too. Transportation issues, education issues, all of those types of things. So a lot of times we're trying to solve a problem by providing an insurance product that really doesn't address the fundamental issues of access. We all assume that the number one reason that people don't receive care is because they don't have insurance. I'll argue that is certainly can be an issue, but it is also not the only problem there. So, Dr. Turner, have y'all ever, or Ms. Turner, excuse me, have you looked at the driving costs, or the other, excuse me, not the driving costs, but the other issues surrounding the cycle of poverty and the access to care?
You know, we have particularly looked at how discouraged physicians are, all medical providers are, because of the regulations that you point out. They went to medical school to treat patients, and they are forced to deal with so much bureaucracy that it's really discouraging and forcing them out of the practice of medicine, far too many of them, reducing the supply of people that are available, and this is particularly acute in rural areas. So yes, I'm very concerned about this I hope unintended consequence of the over-regulation of our health sector, but it's very real for patients.
Okay, thank you. Dr. Book, Ms. Turner touched on something that I think is very important, and that is the brain drain out of the healthcare industry. Can you make a quick comment on that? Do you see that trend continuing, or do you see it reversing as a result of the Affordable Care Act?
We have seen increases in physicians retiring early. I know very few physicians who would tell their children to become physicians. Most of them tell them not to, avoid it as much as possible. We've seen, I've heard on the regulatory side, I've heard comments from physicians that now that they're mandated to keep electronic medical records, it sounds like a great idea, but none of the systems talk to each other, and it ends up just taking more time to accomplish the same thing they accomplished before.
Dr. Book, I'm going to reclaim my last 20 seconds. I hope that as we move forward with this and find solutions, that we are able to truly drive the conversation back to the two most important people in the room, and that is the healthcare provider and the patient. That intimate conversation cannot be had by an insurance company or a government regulator. It has to be had between those two individuals. Thank you.
I thank the gentleman. Gentleman's time's expired. The gentleman from Wisconsin, Mr. Grothman's recognized for 5 minutes.
Sure, we have a couple questions. First thing in general, I think one thing we haven't touched upon is the degree to which Obamacare discourages full-time work, both because of, discouraging hiring of full-time employees, and on an individual basis, cliffs where you can be substantially penalized for working overtime or getting a raise. I know one of the problems we have in our country is we're having a hard time getting the wages up on the middle class. I'd like some of you to comment on the degree to which Obamacare, the way it was set up, punishes people who want to work full-time, sticks people in a situation which maybe they have to go for 2 jobs into 1 job, as well as, according to accountants I talked to, forces people into a situation in which they have to make sure they don't make too much money.
Well, one of the problems with the law is that it redefined a full-time work week as 30 hours, which very few employers felt a full-time work week was 30 hours. And I have talked to far too many, especially small business owners, who've said that what this means is that if they have more than 50 employees and are therefore subject to this, that they have to reduce the hours and often reduce hiring.
Have you heard stories, and my accountants tell me stories of people, depending upon where the cliff is, of people saying, say, I can't make more than $50,000 a year, I can't make more than $60,000 a year, it's going to cost me $3,000 or $4,000. Could you tell me if you are aware of those stories, or elaborate the degree to which we are discouraging people from improving their income? I mean, after all, if you're going to make $90,000 a year, first of all, you got to make $60,000 a year. If you tell people you can't make 60 or can't make 50, it kind of stunts your growth in your career. Any comments on that, Dr. Blumberg?
The economic research is very strong that there has not been employment-related effects, negative effects, as a consequence of the Affordable Care Act. There may have been a small increase in part-time work that was voluntary but not required, and there has been no impact except for possibly a positive small one as a consequence of the Medicaid expansion.
Dr. Blumberg, honestly, talk to some accountants and you will have no problem finding people who are refusing to make more money, because if they make more money, it's going to cost them $3,000 or $4,000 or $5,000.
There may be people you can find like that, but they are more than offset by other individuals who are behaving differently. So on that, there is strong evidence that there has not been a significant negative impact of unemployment of the Affordable Care Act.
It is very, very difficult to capture the opportunity cost, and what it did not happen, the people who did not get jobs, the people who were not offered jobs, the companies that did not grow as a result of this mandate.
Okay, I'll give you one more quick question. I don't know where our minute thing here is.
2 minutes. Yeah.
I am, there we are. I am familiar with what goes on in the private sector, and there are incredible things being done. A combination of self-insurance, a combination of HSAs, together with funding the HSAs on the part of the employer, a combination of in-employer clinics in which we're having substantial reductions in healthcare costs. And this is going on, I think, is one of the major reasons why healthcare costs have not gone up more at this time. Could somebody comment on a combination of those three things and the way in which private sector employers are reducing costs?
Yeah, actually, if you don't mind, Congressman, I'll speak to that. I think it's not just private sector employers, but unfortunately, Congressman Ferguson's not here. It's also some of the providers who are just redesigning it. I think this is one of the interesting unintended consequences of the ACA, is the ingenuity that it sparked in trying to get around the obstacles. And for example, large employers are now moving towards defined contribution through private exchanges. The other thing that I find very interesting is providers moving to direct primary care, where they get rid of all the fee-for-service paperwork. They don't even take the private insurance. You just go to them for primary care, and you buy it like Netflix or cable, $130 a month. I mean, 2/3 of those practices charge $135 a month, and if you need a doctor, they're on retainer. Interestingly enough, they come up with terminology. The ACA actually allows for, I don't know that they envisioned it, that to be offered with a wraparound
I'm going to
coverage.
cut you off. I disagree that that's because of ACA. I think what's going on is there was a race between the private sector that was solving the medical crisis in this country and people who just wanted to throw in the towel. I think the innovation on the private sector would have happened with ACA or not. It's just that
Gentleman's
Congress
time's expired.
But
I thank the gentleman.
Okay.
The chair recognizes himself for 5 minutes. I didn't get a chance to ask questions yet. So I want to first start off by saying I appreciate the discussion that's occurred here today. I especially appreciate the members of the Budget Committee who, for the first time, were on record, and I think they did an excellent job. I want to say on the record that I associate myself with the comments of Mr. Lewis, Mr. Bergman, Mr. Fauzo, Mr. Smucker, Mr. Gates, Mr. Arrington, Mr. Ferguson. Excellent job. I look forward to working with you all. There was some discussion, especially from my friends on the other side of the aisle, that we voted to repeal this insidious law over 60 times and then had little to replace it with. Well, I think, Ms. Turner, you're right. We didn't have a partner in the White House to help us accomplish that, but we made the case to the American people that about how insidious the law was. It was built on lies. If you wanted your plan, you could keep it. If you wanted your doctor, you can keep it. All that nonsense. But our conference also has a replacement plan, and we have several plans from individual members. And none of those plans, in fact, you can find the Better Way plan right here at better.gop. none of the plans are contradictory. It's not a matter of not knowing what we need to replace these things with. It's a matter of the overlapping of bills, getting it done in a way where the American people have a chance to see what could be. And I don't have to remind this panel that back under Speaker Pelosi, we had to pass a bill in order to find out what was in it. I can't think of a more backward or wrong way to legislate. We're going to take our time, and we're going to make sure that we get this right with patient-centered healthcare that's consumer-driven, that allows for competition in a healthy marketplace. I do have some questions. This is not speechifying on my behalf, Mr. Ranking Member. You'd love to hear me talk. I wanted to hear from Dr. Book and Mr. Haislmaier about a particular part of CBO. Of course, this panel has jurisdiction, exclusive jurisdiction over the Congressional Budget Office. But they got Obamacare wrong. Mr. Book, we understand it could be a difficult job scoring out major pieces of legislation, but can you tell us how the original CBO cost estimates have aligned with reality under current law?
The original CBO cost estimates forecast much lower costs than we've seen, and many more people being covered. They originally forecast, for example, a decrease in the uninsured population to 5%. They forecast 30 million people covered in the exchanges. The true numbers are somewhere between 10 and 15% uninsured, depending on how you count it, and about 11 million people covered in the exchange. And when they made their forecast on a repeal last week, they said that they counted as people losing their insurance 7 of the 18 million people covered in the exchanges, when in fact there's only 11 million people covered to start with. It was a very optimistic forecast. I understand it's difficult to make forecasts. In general, I have a lot of respect for the people who work at the CBO. I can't specifically say why they made those mistakes, because they are not,
In your
they don't
work,
really reveal their methods.
Thank you for that. In your work, do you see anything systemically errant about the way CBO is chartered or required to score major pieces of legislation? Anything you want to help with us? And you don't have to say it now. If you want to get back with us later, that's fine. But we have oversight jurisdiction here, and we've pledged to do budget process reform, and this was a major error.
Yes, it was, and I would like to look into that and get back to you with some specifics. In general, they tend to assume that the world looks exactly the same as it does, except for minor changes, and that people aren't going to react and change their behavior in response to a change in the law. But of course, that's the whole purpose of a law.
Could I comment, sir?
No, I want to get to Mr. Haislmaier. Sorry for butchering your name earlier. In the last 59 seconds that we have, what's your account of this? Why did CBO's projections so grossly overestimate coverage gains under the ACA?
I think it's pretty clear that they overestimated the effect that the individual mandate would have on inducing people who were otherwise healthy and not qualifying for subsidies to get coverage, and I think they're still holding to that as well. There are some other minor things that, I mean, I can't fault them on the Medicaid numbers because the court case came in and that sort of changed things. However, in terms of the enrollment in Medicaid, they overestimated the attractiveness of the exchange to people with who weren't being subsidized. And interestingly, when you compare to the Office of the Actuary at CMS, they expected the Medicaid expansion to ramp up slowly. In fact, it came in quite quickly, and they both underestimated the cost of that.
Thank you, and my time has expired. And now in closing, I'd like to yield my closing time to the ranking member, my friend, Mr. Yarmouth, for a thank you.
I thank the chairman. I just want to thank all the witnesses, and these discussions have been going on for a long time in many different forms, and sometimes it gets pretty heated. I apologize for any of the heat that was directed at any of the witnesses, but I thank you for your testimony and your thoughts.
I thank the gentleman. And I thank the witnesses as well, Ms. Turner, Dr. Book, Dr. Blumberg, Mr. Haislmaier, for appearing before us today. Please be advised that members may submit written questions to be answered later in writing, and those questions and your answers will be made part of the formal hearing record. And again, Mr. Book, I'd love to get your answers in writing and anything you'd like to add, Mr. Haislmaier. Any members who wish to submit questions or any extraneous material for the record may do so within 7 days, and with that bit of business completed, I see no other business before the committee, and we remain adjourned.
They did not underestimate the cost, they overestimated the cost. They have been substantially lower than originally estimated. That was totally not true. Thank you. Thank you, sir.
Thank you so much. Thank you very much. I'll have to take a look at that.
You're completely backwards.
Do you want to send me something on that?
I certainly will.
Here, let me give you my card. Wait, let me turn that off.